Recording, and we're going to continue from yesterday's lecture. So I stopped on page 102. We're now going to talk about the gastrointestinal system, okay, or GI system. Right. So we have the following key terms. Digestion is the process of preparing food physically and chemically so that it can be absorbed into the cells. Absorption is the transfer of nutrients from the intestines to the cells. Elimination is the process of expelling waste made up of the waste products of food and fluids that are not absorbed into the cells. Fecal incontinence is the inability to control the bowels, leading to involuntary passage of stool. Okay. So in medical terms, there's a lot of words for poop. Okay, so you have the word stool, just like what's there on your screen. You also have feces. You also have might have also heard, for those of you who've been working in your family's care homes already, or already currently a caregiver, bowel movement or BM. Okay. So those are common terms to refer to poop in medical terms. All right. So there's a lot. All right. I'm gonna skip that part. I just mentioned all of that earlier. Okay, so normal changes of aging to the GI system include the following. Decreased saliva production affects chewing and swallowing. And so to help stimulate saliva production before the elderly person eats, we want to actually have them either brush their teeth or do oral care, or at the very least, have them gargle. So typically, especially if you're working in a long-term care assisted living facility, or even for those of you who are going to be helping out in your family's care homes or adult foster care in the future. One thing that you should be doing to make the eating experience more pleasurable or pleasant for your clients is to actually have them use the bathroom before they eat. So that way they don't suddenly get the urge to pee or poop in the middle of eating their. Okay. And then we obviously you're going to have them clean their hands, or at least use hand wipes to clean their hands before they eat. That's to help to remove any existing germs that they might have on their hands. So if they decide to stick their hands in their food, they won't be getting sick from whatever germs might be on there before you had them wipe or wash their hands. Okay. And while they're still there in the bathroom, in addition to washing their hands, you're going to also have them brush their teeth or put in their dentures or gargle at the very least, okay, to help stimulate their saliva. So that way they can also better taste the food. Dull sense of taste may result in poor appetite. Again, saliva production can also affect their ability to actually taste the food. And that's why we want to actually have them brush their teeth, get put on their dentures and do denture care, or gargle before they eat. Decreased absorption of vitamins or minerals, longer, less efficient digestion. And that's why with a lot of the elderly, they might have poor intake, like say at lunchtime, because they still feel full from breakfast. Or say for dinner time, they'll again tell you that, oh, I'm still full from what I ate earlier. So, and that's why in a lot of long-term care and assisted living facilities, again, instead of giving 3 large meals throughout the day, we're going to give 5 smaller meals instead. So that way the resident or client is more likely to actually eat all of their food. So it's easier for them to digest. They still get satisfied by the amount of food that they're eating. And hopefully we meet all of their dietary needs at the same time. Okay. And then they might also experience more frequent constipation caused by body waste moving more slowly through the intestines. And so, to help prevent constipation, we want them to remain physically active as much as possible. So, even just having them walk up and down the hallways in your home or in the long-term care facility can actually help to prevent constipation from happening. And that's why, even in the hospital setting, for those patients that are actually able to walk, we encourage them to walk. So that way it helps them to recuperate or get better sooner and be discharged sooner and prevent any complications like constipation from happening. Okay. So NAs can help by encouraging fluids and nutritious appealing meals. So make sure that when you are serving them their meals in your family's care homes or adult foster care, that the food looks, appetizing. It looks, is presentable because then people are going to actually want to eat the food more versus it's just put on the plate like any which way. Yeah, it's not going to look as appetizing and enjoyable to eat. Okay. Allowing time to eat and making meal times enjoyable, providing regular oral care. Again, have them brush their teeth or do denture care at least twice a day, and or also have them gargle before each meal. Okay. Making sure that dentures are cleaned regularly, serve plenty of fluids with meals to prevent choking and constipation. So every 2 to 3 bites of food, encourage them to drink something. Okay. It's not especially with the elderly, a lot of them have a tendency to eat their food and then only drink their beverages at the very end. And so they actually drink less fluids, again, increasing their chances of actually suffering from constipation. So instead of having them do that, you want to encourage them every 2 to 3 bites of food to drink something. Even just one sip of whatever beverage that they prefer, as long as they drink something and hopefully consume all of the fluids on their meal tray, then they'll have a good balance of both fluids and food that was served to them. Okay. And also helping residents with toileting so that they have the opportunity to have a bowel movement around the same time each day. So all of us as individuals have our set routine for when we poop. Okay, don't tell me that you don't have that preferred time that you want to go and poop. I won't believe you. Okay. So we want to actually find out when is a typical time that our patients or residents prefer to go and use the bathroom to poo, and actually bring them to the bathroom so that they get that opportunity. Okay. And then give them enough time to actually poop during that time. That being said, if they have dementia or if they're confused or if they're at high risk for falls, you shouldn't leave them unattended in the bathroom. You need to actually watch over them or keep them company while they're using the toilet. Okay, you might be like, what? I'm gonna stay in the bathroom with them. If you're gonna be working in a healthcare facility like the hospital or long-term care facility with certain patients or residents, yes, you actually have to stay in the bathroom with them while they're taking a dump. Okay. That's to help prevent them from getting injured while they're using the toilet. Or if they're confused or forgetful, like if they have dementia, which we'll be talking about in the next chapter, you want to stay with them to remind them. Again, depending on the individual, if they're too shy or it's not your policy and procedure to actually stay in the bathroom with them, you're going to stay outside of the bathroom, close the door or close the curtains, depending on the facility. And then you're just going to stay outside of the bathroom and listen to the resident or patient. What are they doing? Okay. If it's taking more than 5 to 10 minutes for them to actually poop or pee, then just ask them, are you doing okay in there? Are you able to pee or poop? Depending on why they actually went to the toilet. Okay, just to help remind them of what they're supposed to be doing. Okay. All right. And then it is important to observe for and report the following: any difficulty swallowing or chewing, fecal incontinence. So especially if it's new, if usually they're able to go to the toilet on time and all of a sudden they're pooping their pants, that's highly unusual. What's going on with them? Is it because they have an upset stomach? Is it because of something else that's going on? Do they have a neurological condition? Have they had a stroke? Okay, that or did they just have a seizure? What's going on with them? Okay, that they suddenly poop their pants, okay, or underwear. Also, any weight gain or loss, no matter how small, we need to report it to the nurse if you're working within a healthcare facility. And if you're working in your family's care home, again, you want to keep track of your client's weight. At the very least, weigh them once a month, like I was talking about yesterday, and then record it in their chart. And that way, when the care home operator or you as a primary caregiver, for those of you who might become primary caregivers, you need to inform the doctor during that client's routine checkup that about the any weight gain or weight loss, if it's going to be something that the doctor needs to know about. Okay. Also, any loss of appetite if they're eating less than 75% of their meals or snacks, abdominal pain or cramping, what's causing them to get an upset stomach, and obviously if they have diarrhea. Okay, because it's not unusual for people to get diarrhea. What's going on? Was it something they ate? Was it the medication that they just started that's causing them to have diarrhea? Are they intolerant of certain foods? Like if they're lactose intolerant and you fed them something that has dairy in it, then yeah, that's will help to serve as a reminder to you that you shouldn't be serving them anything that has dairy or avoid it as an ingredient in the foods that you serve to them as much as possible. Okay. Or is it something like were they exposed to spicy foods or foods that might be contaminated, okay, or not cooked properly? Okay, so those might all be possible causes of diarrhea. But if the diarrhea continues, if they have more than three large episodes of diarrhea, or if it's more than 24 hours that they're still having diarrhea, even if it's just like two episodes, but it's been more than 24 hours and they're still having episodes of diarrhea, yeah, you need to either have the notify the nurse. Okay, I actually if you're working in a healthcare facility, the first episode of diarrhea needs to be notified to the nurse. You need to remind the nurse that, hey, this patient had diarrhea yesterday and they're having diarrhea again today still. Okay. If you're working in your family's care home, then again, tell the care home operator. So that way we can call up the doctor's office or bring that person to the emergency room for further evaluation and treatment. Okay. All right. Also, if they have any nausea and vomiting, especially any coffee grounds type emesis, and I showed all of you that the yesterday. So if they have coffee grounds emesis like this one, then definitely tell the nurse that means that they're bleeding internally, okay, inside of their stomach. Oh, by the way, I just saw these pictures. Served as a reminder. So I was talking about yesterday for the urinary system about the different colors for urine. So these are the different colors I was talking about. So this is when the urine is at what we call straw colored. It's almost clear. Okay, the yellow color is actually barely noticeable. And then this is light yellow. And then this darker orange color or dark yellow is amber. Okay. All right, and then cloudy versus clear urine. So obviously, if you can see through it, there's nothing floating around in the urine, then it's clear. So that's why I was saying that it looks almost like apple juice. You know how you can see through apple juice? That means it's clear. Well, versus if the urine is cloudy, it might have particles floating around in it. Just like with this one, it looks more like pineapple juice. Okay. Then there's different causes for that. It might be excess sugar in the urine, it might be excess protein, or it might even be back, all of that might be bacteria that's in the urine that the person is putting out. They have a UTI. Okay. Or they might also have mucus strands that's floating in their urine. That also needs to be notified to the nurse. I wanted to find a picture also of when the person has kidney stones. Unfortunately, I couldn't find any pictures online of kidney stones in the urine itself. Okay. This is also what we call tea-colored urine, tea like the beverage, or concentrated urine. So if you see any urine in the person's that that the person puts out or pees, and it's like this, you need to notify the nurse immediately. Okay, this is unusual. It means that either the person is not drinking enough fluids, they're severely dehydrated, or it might be that their kidneys are shutting down. Okay, and it needs to be treated immediately before their kidneys actually do shut down, and that person might actually die as a result. Okay, so even for those of you who are going to be working in your family's care homes, you need to pay attention to your client's pee, whether they're peeing into the toilet or if it's in their diaper, okay, or incontinence briefs, you need to pay attention to the color of their pee. All right. Okay. Going back to the GI system now. Also, if they have constipation, typically in most healthcare facilities or healthcare settings, if the person hasn't pooped in more than 3 days, it's considered constipation. Okay. So if your client hasn't pooped in 3 days, check and see what the doctor has ordered for them under their medications. Are you supposed to give them some medication? Like a pill or suppository to help them poop or not. Okay. If not, again, tell the care home operator so that way they can call up the doctor and check what are they supposed to do for that client. Okay. If you're working in a healthcare facility, obviously you're going to tell the nurse. If they have a lot of flatulence. So flatulence is when they fart. Okay, so typically most of us will actually fart anywhere between at least 1 to 5 times a day. That's normal. Okay, you might be like, really? Yeah. They actually did a study here in the US where they found out that most people typically fart at least 1 to 5 times a day. Okay, and so that's normal. But if your client or resident is farting more than that, or it's continuously farting and they're very uncomfortable, they have an upset stomach and any of the other signs and symptoms, then definitely tell the nurse. Okay, there might be something going on with them. They might have an intestinal infection or something else going on. Okay. Also, if they're hiccuping and it won't stop, or they're constantly starting and stopping hiccuping, if they're belching or burping a lot, then yeah, that's also unusual. If they have bloody black or hard stools, or if there's fresh blood on their stool. So this is what the blackish stool looks like. Again, that needs to be notified to the nurse. It means that the person is bleeding internally inside of their stomach. And so the stomach acid is mixing together with the food. And then when it goes through that person's intestines, when it comes out as poop, it's blackish in color. Okay. That being said, blackish colored stool can also be caused by eating certain foods. So if the person like ate like dinuguan for the Filipinos in this class, if they ate dinuguan or if they ate a large amount of like say spinach or some other dark green leafy vegetables, or if they ate a lot of organ meats like liver, then that can also cause their poop to look blackish in color, or if they're on iron supplements. Okay. But if you know for a fact that your client or your patient hasn't had any of that, then it needs to be notified immediately to the nurse or notified to the care home operator. Okay. So that way they can get it checked out before they bleed too much and actually pass out from the blood loss. Okay. Heartburn and poor nutritional intake. So again, if the person is eating less than 75% of their meals, and this is an ongoing thing where every meal they're eating less than 75%, then yeah, that means that they're not getting enough nutrition. And so they're going to be more prone to weight loss, and that might result in other complications. Okay. All right, and then we have the following key terms. Constipation, again, is the inability to eliminate stool or the infrequent, difficult, and often painful elimination of a hard, dry stool, or if they don't poop at least once every 3 days. Enema is a specific amount of water with or without an additive that is introduced into the colon to stimulate the elimination of stool. So with an enema, let me go over here to my pictures. The most common type of enema that most of you are going to be seeing in the future, if you're ever going to help in administering it, is this one, Fleet's enema, or what a lot of old timers they just call it a Fleet's. So with the Fleet's enema, basically it's a prepackaged enema that you're going to insert the nozzle, this tip right here. You're going to take off the cap, the cover on the tip of the enema. You're going to put lubricant on the tip, and then you're going to insert it into the person's butt. Okay. It's the purpose of the enema, at least with the saline enema, like the Fleets one, is to actually help to flush or loosen the stool so that it can come out more easily. Okay. Um, it might actually cause the person to feel the sudden urge to poop when you're introducing the enema. And so when you're going to give an enema to your patient, sorry, I'm trying to grab mine. So when you're introducing the enema into the person's rectum, just make sure that you squeeze gently. Don't be like, ook, squeeze one time on the bottle. Because if you do that, depending on how much poop has built up inside of that person's intestines, it might just suddenly come rushing out. Okay. Or if the patient or client is straining, like trying to push at the same time that you're actually introducing the enema into their rectum, yeah, their poop might suddenly just come out. Okay. And yeah, it's going to cause a big mess. So just be gentle when you're squeezing it. Don't be like, no, you're going to gently squeeze it when you're introducing it. So if you're working in a hospital, you are not responsible for giving enemas. That is the job of the nurse. Okay, if you're working in the hospital. So I'm looking at you, Ruben. For the rest of you, if you're working in long-term care, assisted living, or in your family's care home, as long as you have been taught how to give an enema to your residents or your clients, then yes, you are actually allowed to give an enema. Okay. Just make sure that when you insert the nozzle into the person's rectum, okay, or anus, you do not insert it more than the actual tip or nozzle. Okay, you're only going to insert it this far into the rectum. And please be gentle, obviously. Um, please don't insert the entire thing all the way up to the end of the cap. I actually had a nurse aide do that and it got stuck. So yeah, that was not fun having to retrieve it. But yeah, you're only going to insert this thing up to here. Okay. Oh, and then if you're going to be working also in a healthcare facility, especially in the hospital or in long-term care facility, we also have a different type of enema. So we that the doctor might order. So we might have to use an enema bag, whether it's the reusable type like this one or a disposable enema bag. And so we would have to use the prescribed um enema mixture as ordered by the doctor, whether it is a soap sud solution, or it might be mineral oil, or it might also be some other prescribed medication that we have to give to that person. Anytime it's a different mixture versus the saline enema, like this fleets, that's the job of the nurse. That's not your job as a nurse aide. Okay. So, if they need to get that enema and you're working in a healthcare facility, you're only going to assist the nurse in positioning that person, helping to put a chucks pad under their butt, and then putting the bedpan underneath their butt while the nurse is giving the enema. That way, when they actually do poop, hopefully it'll go into the bedpan. If it overflows, again, that's why we have the chucks pad ready. Okay. So, but yeah, anything other than the fleet's enema, that's the nurse's job to actually administer in any healthcare setting. Okay. All right, so some facts about constipation. Causes are decreased fluid intake, poor diet, inactivity, medications, aging, disease, or ignoring the urge to eliminate. So obviously, we want to give them that routine, or make sure that we take them to the bathroom when they feel the urge to go to the toilet. Okay. Symptoms can include abdominal swelling, gas, irritability, and record of no recent bowel movement. So one of your responsibilities as a nurse aide in any healthcare setting is to remind the nurse or check the patient or resident's record to see when they last pooped. So if it's been more than 3 days, it's basically the fourth day. Then yeah, remind the nurse that, hey, this patient hasn't had anything hasn't pooped yet, and it's day 4. Okay. Um, if you're working in your family's care home, then yeah, you're going to tell the care home operator and then check the doctor's orders for that particular client. If they have any orders for a suppository or a fleet's enema. Okay. Or some oral medications that they have to take first before you give the enema or suppository. So treatment includes increasing fiber and fluid intake, increasing activity, and possibly medication. So in some healthcare facilities, like in long-term care and assisted living facilities, the nurse aide is allowed to give a suppository. This is what a suppository looks like. No, they don't. The resident doesn't take this orally. Okay, the suppository goes into their butt. All right. So as nurse aides, as long as you have been trained by the facility to give a suppository, then you're allowed to do so. In the hospital setting, if that patient needs a suppository, again, it's the job of the nurse to give the suppository. You as a nurse aide are just going to assist the nurse in like helping to position that person, the patient, while they insert the suppository into their butt. Okay. So you're not the one who's actually going to be inserting it. For those of you who are going to be working in your family's care home or hope to work in a long-term care facility, when you're inserting the suppository, you're going to insert the suppository approximately 1 to 1.5 inches into the rectum. Okay. So yeah, this is actually how we determine how far we are going to stick the suppository. So you have the suppository, and then you're going to stick the suppository further in with your finger. Okay. So we basically use our fingers, our digits. So this is typically about more or less 1 inch. And then up to the second knuckle, that's about 2 inches. So only about midway for 1.5 inches. Okay. But you want to make sure that when you're inserting it, you insert it past the rectal ridge. If you ever have to insert a suppository, believe me, you're going to know what I'm talking about, because you're going to feel that ridge once you get past the actual rectum or muscle, their butt muscle, when you're inserting the suppository. Okay. Yeah, that rectal ridge is actually a bone. that you're going to feel. So you're going to put the suppository past the bone. So yeah, typically it's not more than an inch and a half to actually insert it, including the length of the suppository. Okay. All right. Then we have fecal impaction. So NA should know these facts about fecal impaction. It's caused by a hard stool that's stuck in the rectum and cannot be expelled, resulting from unrelieved constipation. So with fecal impaction, if the person has had constipation and it's not relieved, like they still aren't able to poop even after you've given them medication, oral medication, and or suppository and an enema, and poop still can't come out, that poop is gonna keep on like getting compressed and or compacted inside of the person's intestines, and that's when you get fecal impaction. Okay, so yeah, it's going to get bigger and bigger inside of their butt, and it's going to be more difficult for the poop to actually come out when it becomes impacted. That being said, even though I've worked for over 30 years in as a nurse, both in the hospital and long-term care facilities, uh, I've only ever actually had 3 cases of fecal impaction that I've had to deal with. Okay. And 2 out of the 3 was actually in long-term care, and I only had one that I actually had to take care of when I was in the hospital. And that patient actually came from a long-term care facility. Okay. So yeah, it's not typical for a person to have fecal impaction. So symptoms can include no stool for several days, oozing of liquid stool. So it's gonna look like they have liquid diarrhea, but unlike with diarrhea where it's large amounts of liquid stool, with a fecal impaction, when they have that liquid stool coming out of their butt, it's going to be only small amounts. So that's actually leaking from around that hard ball of poop that's inside of their rectum. Okay. Also, they'll have cramping, abdominal swelling, and rectal pain. It's actually going to hurt for them, for the patient or for the resident when they're trying to poop. It hurts because imagine a hard ball of poop just stuck in there and it's too big to actually come out. So it's going to hurt them when they try and strain or try to pass that poop out of their butt. Okay. So treatment would be a nurse or doctor inserts 1 or 2 glove fingers into the rectum, and then we're going to break that mass or poop into fragments so that it can be passed. So if that does happen, and you have, if you're going to be working in a healthcare facility and your patient or resident has fecal impaction, that's not your job as a nurse aide to actually dig out that poop, okay? It's the job of the nurse or of the doctor. So, if they try and pass it on to you, you do have the right to refuse. Okay? You can tell them that, nope, that's not in my job description. All right? So, that's outside of your scope of practice. The reason that we don't allow you as a nurse aide to dig out that poop is you might be go in too far, or you might actually be a little too forceful in digging it out and actually cause internal damage to your patient or resident. And that's why it's the responsibility of the nurse to do it or doctor. Okay. Or in rare cases, they might even have to have surgery to remove the impaction because it's just too much to actually safely remove manually, meaning digging it out by hand. Okay. So, so prevention would include a high fiber diet, plenty of fluids, an increase in activity level, and possibly medication. So yeah, they might be placed on something like Metamucil or some other medication like that, like Dulcolax pills to make sure that they have increased fiber in their diet also so that they can poop more regularly. All right, and then we have hemorrhoids. So hemorrhoids are caused by enlarged veins in the rectum and or outside the anus, resulting from an increase in pressure in the lower rectum due to straining during bowel movements, chronic constipation, obesity, pregnancy, and sitting for long periods of time on the toilet. So yeah, don't be watching TikTok or YouTube videos while you're sitting on the toilet, because if you sit on the toilet for too long, that actually increases your chances of developing hemorrhoids. Okay, so let me go over here to my pictures. Let me just close some of these. So you have your internal and external hemorrhoids. So with external hemorrhoids, you can actually see like an unusual extra tissue, okay, or like flap of skin hanging out of the person's rectum. And that extra like skin or external hemorrhoid, it can get easily irritated whenever that person poops or whenever they're wiping their butt after they poop, and it could bleed easily. Okay. And it can also, it gets itchy easily because when that extra skin rubs against that person's underwear, then it's actually going to irritate it, and yeah, it's going to feel itchy and very uncomfortable. And then you also have internal hemorrhoids. You can't tell just by looking at that person's butt that they have a hemorrhoid, but anytime that they poop, there might be fresh blood or bright red blood on the poop, especially if it's hard formed poop. And so that's how we typically know that that person has an internal hemorrhoid. Or they might complain of pain anytime they poop, or they might also complain that it feels itchy inside of their rectum. Okay. So now on the out, you can't tell from the outside that they have a hemorrhoid, but they'll tell you that, yeah, it feels itchy all the time on the inside. And no, it's not always worms. That person might actually have internal hemorrhoids. Okay. Yeah. So symptoms can include rectal itching, burning, pain, and bleeding, especially after they poop. And then treatment would be medications, compresses. So if their hemorrhoids are inflamed, especially if they have external hemorrhoids, then we would use alternating cool and warm compresses on the affected area to help to relieve the pain and discomfort and also to decrease swelling and inflammation. Okay. So yeah, we're going to put ice packs down there covered with a towel, and then alternate that with warm compresses, which is basically either a warm pack or a warm washcloth, warm wet washcloth over down there on their butt to help to reduce the swelling and inflammation. Okay. Or sitz baths and possibly surgery. So with a sitz bath, where's my picture of a sitz bath? So this is what a typical sitz bath looks like. It's basically a special basin that has a bag attached to it that we put inside of the toilet bowl, and then we fill it up with a warm water together with medications ordered by the doctor, or we might also put, instead of that, we might just put Epsom salts. Okay, into the water, and then we're going to actually have the patient or resident basically soak their butt in that sitz bath for anywhere between 15 to 20 minutes. And they're going to do that every time they poop, or at least 2 to 3 times a day until the swelling and inflammation goes down. Okay, so you make sure that you follow the doctor's orders or what's written in the care plan regarding the use of the sitz bath. Also, do not use anything other than what was ordered in the care plan or by the doctor to be added to the warm water. Um, Unfortunately, I have taken care of some patients in the past where they just add random stuff into the water that they are going to be soaking in, and it caused infection. Okay. I actually had one patient that she mixed in honey. What was it now? Honey. petroleum and whiskey in her thing. I was like, what was the purpose of that? She says that it had medicinal value. Okay. And then she also added some herbal teas or leaves in there. But yeah, it just caused her to have a severe infection on her butt as a result. So we don't do that. Okay. Make sure you follow the doctor's orders. So, yeah. And some healthcare facilities, though, we don't have anything fancy like this sitz bath basin. Instead, like over at Kapilani, we actually will just give them, where's my thing? We'll give them a special container that we'll fill up with warm water. And then every time that the patient goes to pee or poop, they're going to use that to irrigate that affected area. Okay. So instead of using, toilet paper, they're going to be using that, special, container for, actually washing their private area. So it's similar to the purpose of a bidet, for those of you who might be familiar with what a bidet is. So instead of having that toilet paper rubbing against the affected areas, we would just flush it instead with warm water. Okay. All right. So also just remember that NA should be careful to avoid causing pain while cleaning the anal area. So just like I was saying yesterday, if you have a client or resident that has a lot of pee or poop on the left over on their skin, even with the when you're using the wipes to clean them up, you can also fill up a spray bottle with warm water if you're in the home care setting, and then just use that to rinse the affected area, including if they have a hemorrhoid. Okay. If you're working in a healthcare facility, then yes, use the perineal cleanser or spray to actually cleanse that area. So that way it's less irritating when you're wiping them down there. Okay. All right, and then some facts about diarrhea. It's caused by a frequent elimination of liquid or semi-liquid feces resulting from infections, microorganisms in food or water, irritating foods, and medications like antibiotics. Symptoms can include abdominal cramps, urgency, they feel the constant urge to go and poop, nausea, or vomiting can accompany diarrhea. And treatment would be medication, increase in certain fluids, and change of diet. So an increase of certain fluids, we would actually want to replace all of the fluids that they lose when they're having a diarrhea episode. So you want to encourage that person to drink, like say Pedialyte. They can also drink other beverages, whatever they prefer to drink, as long as it doesn't have caffeine in it or it's not something that they are intolerant of, obviously. So we're not going to serve them any soda unless it's a caffeine-free soda. You can also give them broth, like chicken broth, beef broth, or vegetable broth if they're a vegetarian. You can, we do not give them any tea or coffee. If they insist on drinking tea, then we'll give them either green tea or some other herbal tea, as long as it's not something that will stimulate their intestines or irritate it further, increasing their diarrhea. Okay. Coffee, yeah, we typically will tell them no, they're not allowed to have coffee, even if it's decaf, because that might actually stimulate their bowels. We don't give them milk or yogurt or anything like that because, again, that might actually irritate their stomach even more or intestines even more. And it might actually, in some instances, it might cause their poop to become um, have more mucus in it. So, yeah, we don't want that either. Okay. Uh, they might also be temporarily placed on a BRAT diet by the doctor. So BRAT stands for bananas, rice, apples or applesauce, and toast. So the purpose of a brat diet for that individual is that all of these foods are high in fiber and in potassium to replace all of the potassium that they lose when they have an episode of diarrhea. And also the fiber in these foods will help to bulk up or make their poop more firm in consistency. Okay. So that being said, don't automatically put your resident or client on a brat diet unless it has been ordered by the doctor. Also, this brat diet shouldn't be used more than 24 hours. If they're going to still have diarrhea after 24 hours, and yeah, we don't want them to still be on a brat diet. We need to find out exactly what's causing them to have that diarrhea. Okay. All right. Let me close some of these pictures. Okay, I still need that. All right. So we now have gastroesophageal reflux disease or GERD. So it is a chronic condition in which liquid contents of the stomach back up into the esophagus. Liquid can inflame and damage the lining of the esophagus, causing bleeding or ulcers, and scars from tissue damage can narrow the esophagus and make swallowing difficult. So with GERD, so the esophagus is the tube that leads from our mouth or throat down into the stomach. And so when the person has GERD, the stomach acid, it's not going to stay inside of the stomach like normal. Instead, it's going to go back up into the esophagus, damaging the esophagus, and also causing damage to the inside of that person's stomach. Okay. And so if they start bleeding as a result of all of that stomach acid irritating the inner lining of their stomach and esophagus, that's when the person develops ulcers. Okay. And it can actually also affect their swallowing and digestion. So, facts about GERD: heartburn is the most common symptom of GERD, and treatment includes medications. So, the doctor might order medication for that person to take to actually help to decrease or the amount of stomach acid that the person produces. That we also want to serve the evening meal 3 to 4 hours before bedtime, and that's why in a lot of healthcare facilities, dinner is served as early as 5:30. Okay, you might be like, what? Yeah. Dinner might be served as early as 5:30. That's to allow the person to fully digest their food before they go to sleep. Because typically in most healthcare facilities, bedtime is early as 8:30, 9 o'clock. So we want to make sure that they've fully digested their food before they go to bed or go to sleep. Okay. Not lying down until 2 to 3 hours after eating, using extra pillows to keep the body more upright during sleep, or if they have a hospital type bed or mechanical bed, then just raise the head of the bed until it is at a comfortable position for that individual. So either 30-degree angle or 45-degree angle. You might notice that I'm angling my hands. So 30-degree angle, the head of the bed would actually be this high. 45-degree angle, the head of the bed would be angled this high. Okay. Let's see. Serving the largest meal of the day at lunchtime instead of at dinner time, like most people do. Instead, we would serve them their largest meal at lunch. Also, eating smaller meals throughout the day, so they would get anywhere between 5 to 6 small meals instead of having the 3 large meals, like most of us typically eat. Also, reducing fast foods, fatty foods, and spicy foods because those increase stomach acid. Stopping smoking because that also increases stomach acid. Not drinking alcohol, that also irritates the lining of the stomach and increases stomach acid. And wearing loose clothing, especially around their abdomen. Because when they wear tight clothing, that actually squeezes the stomach. And so, yeah, it increases the amount of stomach acid that goes back into the esophagus. Okay. All right, and now we have the following key terms. Ostomy is a surgically created opening from an area inside the body to the outside. So there's a lot of different types of ostomies, but the one that we're going to be focusing on in this chapter is going to be the colostomy or ileostomy. Okay. Um, so yeah, the actual procedure, okay, that the person has, or the surgical opening is going to be called an ostomy. So colostomy, ileostomy, if they have one in their upper airway, then they aren't able to breathe through their nose or mouth. The doctor might form a tracheostomy. Okay, so that's another example of a ostomy. Okay. And then the actual opening itself is called a stoma. Stoma is an artificial opening in the body. Okay. So remember those two terms. That's going to be in your future tests. All right, so some facts about ostomies. It may be necessary due to bowel disease, cancer, or trauma. Colostomy is a surgically created opening into the large intestine to allow stool to be expelled. And with a colostomy, stool will be generally be semi-solid. With an ileostomy is a surgically created opening into the end of the small intestine to allow stool to be expelled. And with an ileostomy, stool will be liquid. So whenever that person's going to poop, they're not going to be pooping through their butt. They're going to be pooping through their ostomy. Okay. It's going to come out through their colostomy. Right after surgery, for anywhere between up to 3 days to sometimes as long as a month. The person might still poop small amounts through their butt, but typically, yeah, all of their poop is going to be coming out of the ostomy instead, the colostomy or ileostomy, depending on which one they had. And a disposable pouch fits over the stoma to collect the feces and is attached to the skin by adhesive. A belt may also be used to secure an ostomy bag. Okay, so let me go over here to my pictures. So this is a picture of someone who has a colostomy. So again, when the person poops, instead of pooping through their butt, they're now going to be pooping through that colostomy, through the stoma that they have in their abdomen. Okay. And then we would use a special adhesive or wafer, we call it, to actually attach a pouch that will collect the poop. They're not going to be pooping out and then getting it all over their clothes. No, it's going to be collected inside of the ostomy pouch, like this one. Okay. So yeah, this is actually a two-piece system, which is the most common type, where you have the wafer, okay, or adhesive that stuck onto the person's abdomen. Usually that's changed every 3 days by the nurse, not you as a nurse aide. It's going to be changed every 3 days. And then the pouch, depending on the facility or healthcare setting that you're going to be working in, typically we would keep the pouch anywhere between 3 days, uh, yeah, 3 days use or up to a week, like in the home care setting. You know, and you're like, what? Yeah, they're going to be pooping in that bag for up to 3 days or 7 days, depending on the person's healthcare insurance or the healthcare setting. So every time they poop, or if you notice that the pouch is about half full, you don't want to wait until it's completely full, believe me. Otherwise, it might burst. Anytime that the pouch is anywhere between 1/3 to half full, you want to empty it out of its contents. So you're going to detach the bag, you're going to empty the content, and you're going to put it into like a bedpan or a basin, carry that to the toilet, and then you're going to empty out the contents into the toilet, rinse the bag, disinfect it with the prescribed skin-safe disinfectant. Don't just use Lysol or Clorox on that pouch because those are toxic to the skin. Okay, you need to use whatever is ordered by the gastroenterologist to use with that pouch. If you do need to use disinfectant. Okay. So yeah, there are skin safe disinfectant sprays that we can use to actually disinfect the inside of the pouch so it doesn't smell. Otherwise, yeah, we just rinse it out with water. If you want to, you can use soap and water, but yeah, we usually just use water to rinse it out. Okay. And then we just empty out as much of the water from the pouch and then reattach it back onto the wafer. Okay. But yeah, you're going to make that pouch last 3 to 7 days. We don't just, oh, it's full, toss it. No, the healthcare insurance companies do not pay for that many pouches, okay? Because every time that person eats, they're going to have poop coming out into that bag. All right. It's not gonna, oh, they're gonna be pooping once every 3 days. No. Every time they eat, they're gonna have poop coming out of that pouch, into the pouch. Okay. So you need to empty it out every single time. Um, and then, yeah, they might also wear a belt to help to secure the pouch in place, especially if they walk or move around a lot or are physically active. Just to ensure that the pouch stays in place, they might have to wear, they might choose to wear an ostomy belt like this one, or they might wear a girdle like this one to help to secure the pouch in place. Or if you have a confused resident or client, then you might use a girdle like this one to help to keep it in the pouch in place. So that way your resident or client isn't playing with the pouch and cause it to get detached, or they don't play with their poop. Okay. I actually had a resident when I was still working in long-term care that she liked to play with her stoma. And yeah, she actually hurt herself like severely. So she had to go to the hospital as a result. But make sure that if it's ordered in the care plan that you're going to use a girdle on them to protect or secure the pouch, that you always securely fasten it back after you've cleaned the colostomy pouch. Okay. Okay, so some guidelines for ostomy care. Make sure that the resident receives careful skin care. Make empty and clean or replace the ostomy bag whenever stool is eliminated. Always wear gloves and wash your hands carefully. I mean, that should be common sense. You're handling someone else's poop, even if it's in a bag. And so, yeah, you want to wear gloves and then make sure that you wash your hands afterwards. Okay. If your client or resident is able to empty out the ostomy bag on their own, remind them to wash their hands afterwards. Oftentimes we'll have people who have an ostomy bag and they don't wash their hands because their thing is that, oh, it's protected by the bag. Well, the poop can actually get onto the outside of the bag and they might not even realize it. Okay, so always encourage them to wash their hands after emptying out the pouch. Okay. Also, be sensitive and supportive when working with residents with ostomies, and always provide privacy for ostomy care. So, whenever you're going to be doing ostomy care, emptying out the pouch or detaching the pouch to empty it out in the bathroom, like if the person is lying in bed, always make sure that you give them privacy by closing the privacy curtain around their bed. If they're going to be lying in bed when you do the ostomy care, and or closing the room door so that way people know that you're doing something in the room, or if you're going to help them while they're in the bathroom, then make sure that you close the bathroom door for their privacy. Okay. All right, I'm not going to go over the procedure of caring for an ostomy because it varies from facility to facility, okay, or from person to person. The thing to remember about also taking care of a person who has an ostomy, and this is also there in your book on page 106, is number 17. Okay. So on number 17 on page 106, report any changes in the resident or client to the nurse or to the care home operator, and note any changes in the stoma and surrounding area. A normal stoma is red and moist and looks like the lining of the mouth. So just like that picture that I showed a while ago. Okay. Should be nice and healthy like this. And call the nurse if the stoma is very red, blue, if swelling or bleeding is present, and report signs of skin breakdown or irritation, like a rash or any pimples or bleeding around the stoma. So if you notice that when you take off the ostomy pouch and the exposed skin around the stoma looks irritated or looks infected, tell the nurse. Okay. So, whenever you are going to clean out the pouch, you're also going to clean the stoma and any exposed skin that is, exposed through the wafer. Okay. So if there's any skin around the stoma that you see it's covered in poop, obviously you're going to clean it up just like you would during perineal care. Okay. You're going to use a wipe to clean that gently. All right. The other thing too that you need to be aware of is that if you notice that your patient or resident who has an ostomy has not pooped, okay, after eating or within 4 hours of eating, tell the nurse. That means that they're constipated. Something's going on. They might actually have an intestinal blockage. And if they do have intestinal blockage, then that's a medical emergency. Okay. So, they need to actually get treated as soon as possible before, they either get an intestinal infection or their intestines might actually explode. And yeah, I'm not exaggerating. Okay. They could die as a result of that intestinal blockage. Okay, moving on now. We're on the endocrine system. Okay, so we're still on page 106. So we have the following key terms. Glands are organs that produce and secrete chemicals called hormones. Hormones are chemical substances created by the body that control numerous body functions. Okay, and then yeah, the endocrine system, there are a lot of glands. You do not have to memorize all of them. The thing to remember is that so hormones are carried by the blood to organs in order to achieve the following: maintain homeostasis through hormone secretion, influence growth and development, maintain blood sugar levels, regulate calcium and phosphate levels, regulate the body's ability to reproduce, and determine how fast cells burn food for energy. So normal changes of aging to the endocrine system include the following: decrease in levels of hormones such as estrogen and progesterone, less production of insulin, and the person is also less able to handle stress. So NAs can help by encouraging proper nutrition, trying to eliminate or reduce stressors, and offering encouragement and listening to residents. Okay. And it is important to observe for and report the following: headache, weakness, blurred vision, dizziness, irritability, sweating, or excessive perspiration, especially if it's not that hot in the room where they are and yet they're sweating a lot. What's causing them to sweat? Okay. It might be that they have a fever, or it might be that they're actually having a hormone imbalance, especially with women who are in menopause. They might have sudden hot flashes that will cause them to sweat a lot. Okay, the problem or issue with when the person is sweating a lot is, again, they're going to be losing a lot of fluids, and so they can easily become dehydrated. And if their hormone levels are fluctuating a lot, then that can also affect their other body systems, not just their hormones. Okay. Also, if you notice any change in normal behavior, confusion, change in mobility, change in sensation, numbness or tingling in the arms or legs, they might complain also pins and needles feeling in their hands or feet. Yeah, that's unusual. They might have diabetes and not even be aware of it, or have some other endocrine imbalance. Also, if they have weight gain or weight loss, loss of appetite or increased appetite, increased thirst, frequent urination or change in urine output, hunger, dry skin, skin breakdown, sweet or fruity breath. Again, like I mentioned back in chapter 2, the person's breath will smell kind of like apples, bananas or papaya. Okay. But if you know that they didn't eat anything like that, but their breath smells like it or it smells like acetone, you need to tell the nurse their blood sugar levels are really high. Okay. And so their body is actually excreting or producing what we call ketones. And that's causing that sweet or fruity breath or acetone smell. Not just to their breath, actually, even their sweat is going to smell like that. Okay. Sluggishness or fatigue, and hyperactivity. So we have the following key terms. Diabetes is a condition in which pancreas produces too little insulin or does not properly use insulin. Insulin is a hormone that converts glucose from the blood and into the cells for energy for the body, and glucose is natural sugar. Also, we have prediabetes, which is a condition that occurs when a person's blood glucose levels are above normal, but are not high enough for a diagnosis of type 2 diabetes. And then we also have gestational diabetes, which is a type of diabetes that appears in pregnant women who have never had diabetes before, but who have high glucose levels or who are pre-diabetic during pregnancy. Okay, so it might be that the woman is going to be at higher risk for gestational diabetes if they were pre-diabetic before they even got pregnant. Okay. Or if they have gestational diabetes, okay, it increases their risk for actually developing type 2 diabetes even after they deliver the baby. And that's why it's so important that women go for checkups while they're pregnant. It's not just for the sake of their baby that they're going for a checkup when they're pregnant, but it's also for their own health to see how well they're doing. Okay. And if they're diabetic, then yeah, we want to maintain their blood sugar levels within the normal range so that way it doesn't affect their health or their babies once the baby is delivered. Okay. Or born. Let me just close some of these. All right. So, again, with diabetes, the pancreas produces too little insulin or does not properly use insulin, and glucose collects in the blood, causing circulatory problems. Two types of diabetes are type 1, which is typically diagnosed in children and young adults and will continue throughout the person's life. And then we also have type 2, which is considered the milder form. But and typically, it's when the person is diagnosed later in life or during pregnancy as being having type 2 diabetes. So again, pre-diabetes, it describes blood glucose levels above normal but not enough for a diagnosis of type 2 diabetes. Did someone have a question? Oh, okay. I know what you're talking about, Ruben. Okay, so the following can be signs of diabetes: excessive thirst, extreme hunger, frequent urination, weight loss, high levels of blood sugar, glucose or sugar in the urine. So, like I mentioned a while ago, when I was showing pictures of urine, if you notice that their urine is really cloudy, and they're diabetic, it might be that either they're excreting a lot of protein into their urine or they're excreting a lot of sugar. Okay, excess sugar. And so you might also notice that their urine actually smells really sweet or it's really sticky in consistency, almost similar to like a thinner version of pancake syrup. Okay. And I've even had some patients when I was still working in the hospital. I've had patients actually tell me that when they first noticed that they were diabetic, because ants were attracted to their urine, or they noticed a lot of ants in their bathroom, or cockroaches even. Like, okay. So that's what sometimes you might notice in some individuals. Okay. Especially if their blood sugar levels are not under control. Okay, they might also have sudden vision changes, tingling or numbness in the hands or feet, feeling very tired much of the time, very dry skin, sores that are slow to heal, and more infections than usual. So. Diabetes can cause the following complications. Changes in the circulatory system can cause a heart attack, stroke, poor extremity circulation, poor wound healing, and kidney and nerve damage. Damage to the eyes can cause vision loss and blindness, and that's why it's so important that with the elderly or with people who are 40 or older, you go for yearly eye exams just to make sure that your eyes are good, especially if you have any pre-existing um, medical conditions like heart disease or diabetes. Okay. Diabetes can also lead to leg and foot ulcers, infected wounds, and gangrene due to poor circulation and impaired wound healing. So with gangrene, basically it's when the muscle or tissue is dead. Okay, it's not gonna heal, the wound's not gonna heal, the skin or muscle is not gonna grow back. It's dead. The surgeon will actually have to remove the dead tissue, or they're going to actually have to amputate or cut off the body part affected by the gangrene. Okay. And that's why we want to be very careful when we're taking care of a person who's diabetic. So that way they don't develop gangrene. We don't want it to reach that point as much as possible. Okay. And then insulin reaction and diabetic ketoacidosis are also serious complications. And we've talked about the signs and symptoms for both of those conditions in chapter 2. Okay, so care guidelines for diabetes, follow diet instructions exactly. So if you're working in a healthcare facility, it's fairly easy. Just make sure that the person eats whatever is being served to them on the meal tray. If they ask for extra food, or if the family delivers any delivers or brings any food, or if the patient or resident orders Uber Eats or some other food delivery, then tell the nurse. So that way the nurse can um, check whatever the person, whatever food that was brought by the family or other visitors or that was ordered by the patient. And then they can educate them on what they should and shouldn't eat. Okay, that being said, we can't really stop them from eating what they want, but we can at least help to educate them better and hopefully they'll make smarter choices. Okay. Also, if you're working in a healthcare facility and you're serving the dietary tray to your patient or resident, make sure that you give them the sugar-free jams or jellies that are available, or pancake syrup. There's also the sugar-free version. And do not give them regular sugar or any honey. You're going to give them instead sugar alternatives. So that includes Splenda, Equal, what's the other one? Equals, the blue one, Sweet and Low's the pink one. Okay. And in some facilities, it's not that common. We also have Nativia, yeah, the yeah, of if they are allowed to have that. In most long-term care facilities and assisted living facilities, we don't typically have that as a one of the alternatives. Instead, the three common ones are either Splenda, Sweet and Low, or Equal. Okay, so make sure that you put any of those three sugar alternatives onto the tray if your resident or patient is diabetic, and do not give them anything that has sugar in it. Even for the dessert, make sure that it's something that is sugar-free or low sugar in content. Okay. And then also notify the nurse if the person eats less than 75% of the food that's on their tray. Okay. Let's see. For those of you who are going to be working in your family's care homes, just make sure that, again, you follow the meal plan for your clients as much as possible. And also do not serve them anything that, no concentrated sweets. Okay. And again, check the labeling on any condiments that you're going to be serving them. Make sure that it is either sugar-free or low sugar in content. Okay. And then again, also sugar alternatives instead of sugar itself. let's see. Um, Encourage residents to follow their exercise programs. They should have an equal amount of activity versus the amount of food that they eat. Otherwise, if they're really active, but they don't eat as much to actually meet the amount of activity that they're having, that's when their blood sugar levels will drop. If they're eating a lot, but they're not physically active, that's when their blood sugar levels will skyrocket. So the activity level or exercise and the person's consumption of food should be equal to each other to maintain the blood sugar levels also at a more normal range, right? Observe the resident's management of insulin doses. So make sure that if you're working in a healthcare facility, if you know that the person just received their insulin from the nurse, that that person is going to receive their meal tray within at least 10 to 15 minutes afterwards, depending on the type of insulin injection that they received. Okay. For those of you who are going to be working in your family's care homes, you are not allowed to give insulin to your clients. Okay. Because that's an injection. If they do need insulin, then they should be doing their insulin on their own. Okay. So just so you know, FYI. Um, Also, perform urine and blood tests as directed. If you're going to be working in a healthcare facility, like in the hospital or in a long-term care facility, here in the state of Hawaii, you can actually check blood sugar levels using a glucometer like this one, if you have been trained to do so. Okay. If you have not received training within your facility on how to check the blood sugar levels, even if you know how to do it, because maybe you check your own blood sugar levels or you have a family member that you help to do it on, you're still not allowed to do it within the facility. Okay. But if you've been trained by the facility to do it and the nurse asks you to check a patient or resident's blood sugar level, then it's okay for you legally to do it. All right. So just make sure you follow your facility policy and procedure regarding that. Um, if you're working in home care, okay, if you're working in home care, it's becoming more common nowadays that with diabetic patients or clients that they're also actually able to monitor their own blood sugar levels using a device like this one, where it's actually a patch that has a needle in it that they attach either on the back of their arm, upper arm, or on their abdomen. And then they're just going to use an app that they can download onto their cell phone and they can just scan it and then it'll tell them what their blood sugar levels are. So if they're supposed to be checking their blood sugar levels after they eat or before they eat, before every meal, then yeah, they can actually check and see what their blood sugar ranges are at. We want to make sure that they stay within limits. Okay, as ordered by the doctor or as written in the care plan. Anytime that you notice that their blood sugar levels are constantly high or their monitor is constantly beeping or alarming, yeah, we need to check their blood sugar levels manually using the glucometer like this one, just to confirm that yeah, it's still within range or not. Because sometimes, yeah, this thing it actually has a very good accuracy. It's 98% accurate. But sometimes, depending on how well the person scans it, it can give a false high reading. Okay. And that's why we would check it again using the machine. Okay. If you notice that it is abnormally high, and then after, if the person is showing any signs and symptoms of ketoacidosis, you need to either call 911 or bring them to the emergency room as soon as possible. Okay. If you're working in a home care setting. If you're working in a healthcare facility like the hospital or long-term care facility, and you notice that your patient or resident's glucometer, okay, their Dexcom is beeping a lot, or alarm, their phone is actually beeping a lot, then you need to notify the nurse. So that way we can check it for ourselves and then give them additional insulin as needed. Okay. So, by closely monitoring that person's blood sugar levels, hopefully we can maintain their blood sugar levels within a normal limit, and yeah, it'll less likely cause complications in the future. If the person has type 1 diabetes, they might also be on an insulin pump like this one. Okay, so with an insulin pump, it's going to have a needle that is inserted either in the abdomen or on the back of their upper arm. Okay, and then it's going to have this tubing that's connected to the pump, and inside of this pump is an insulin cartridge or vial. And so it's going to actually have a preset amount of insulin that's going to be constantly delivering to the person every hour. Okay. And then depending on what their blood sugar levels are, which they're supposed to check, especially right after they eat, then they can also give themselves a bolus or extra dose of insulin to help to lower their blood sugar levels to a more normal limit or range. Okay. So, yeah, again, by maintaining their blood sugar levels within a normal range, they're going to remain healthier for longer, and of course, they're going to live much longer. Okay. Perform urine and, oh, sorry, I already said that. Give foot care as directed. So very important that anytime that you're going to help that person to take a shower or a bath or help them get dressed or put on their shoes or slippers, check their feet and skin at the same time. Look for any skin irritation or breakdown. If they have any bruises, rashes, skin irritation, bruises, it needs to be reported immediately to the nurse. Okay. And so that way we can monitor it more closely to make sure that it doesn't become gangrenous. All right. We don't want it to get to that point. Also encourage comfortable shoes made of material that breathes and socks made of natural fibers. We want to make sure that the person is wearing the appropriate size footwear for their feet. And their shoes aren't going to be too big for them, because then they're going to end up tripping and falling and hurting themselves. We don't want them too tight, because that can actually press on their feet and cause nerve damage, increasing the numbness and tingling. And we also don't want it to cause blisters on their skin, because those blisters, if they don't heal properly, can again turn gangrenous. Okay? So, socks that are made of natural fibers can help to dissipate sweat, so that way the person is less likely to develop a athlete's foot or other fungal infection. Okay. All right, so this is a picture of a gangrenous toe. So if you look at the picture, the tissue, okay, the muscle on on the tip of their toe is already turned black. That's gangrene right there. That is not going to heal anymore. So the surgeon would actually remove or debride that dead tissue, or in this case, they actually had to amputate the person's toe. Because if you look over here on the lower part, it's actually already purple. Yeah, their toe's not going to be able to be saved. So they would amputate this already. Okay. So we don't want our diabetic patients or residents to get to that point. So if they hurt their toes, or they have a rash or anything like that, tell the nurse as soon as possible. Okay. Yeah. I actually took care of a patient when I was still working in the hospital. He stubbed his toe when he was going up some stairs, and it left a nasty bruise on the tip of his toe. And his wife told him, "Oh, go and get your toe seen by the doctor just to be on the safe side." Well, he ignored her. That bruise actually turned into a blister that became infected, and then it became gangrenous, and it actually smelled nasty, according to the wife. So nasty that she couldn't even tolerate being around him, so she kicked him out of the house. Well, because of the gangrene, the infection actually spread to his bloodstream. He turned what we call septic, and so he was feverish and confused, and he ended up passing out in a park. Okay. And then his toe, because it was gangrenous, it just fell off on its own. Yep. And so passerby who saw the poor guy pass out in the park, thankfully they called 911 for him. And then this is the funny part. Some of them actually saved the dead toe and sent it with him uh, with the paramedics when he went to the hospital. So when he got admitted to my floor and they handed me the bag, I was like, "What is this?" Because it was wrapped in a napkin uh from dirty napkin. I was like, "What is this?" And they're like, "Oh, just open it up and you'll see." So I was like, "Okay." So when I opened it up, yeah, it was his gangrenous toe. That stuff was nasty. Okay. But yeah, he still wanted me to save it for him. He didn't want to be buried, he said, without that toe. So I was like, "Okay." But um yeah, he ended up actually losing half of his foot because that infection had and gangrene had spread all the way up halfway his foot. So if it had only gone to get it seen earlier, he might have still kept his half of his foot, including his toe. But no, he was hardhead. Okay, so we do not want that to happen to our residents or clients, right? Okay, then we have the following key terms. Reproduce is to create new human life, and gonads are sex glands. Okay, so obviously in the reproductive system, the female reproductive system and the male reproductive system are different from each other. Uh, with males, they have the testis, scrotum, and testosterone. And in females, you have your ovaries, fallopian tubes, and the uterus, and estrogen. And reproductive system allows humans to reproduce. So normal changes of aging to the reproductive system include the following. For a female, menstruation ends. They also experience a decrease in estrogen that leads to loss of calcium, causing brittle bones and potentially osteoporosis. And also, they'll have drier, thinner vaginal walls. For males, they'll experience a decrease in sperm production, and they might also have an enlarged prostate gland. So going back over here to our picture of the male reproductive system. The prostate gland is actually located slightly below, and underneath the bladder. Okay, so when the prostate gland becomes enlarged, it can actually press on the bladder, causing the male patient or resident to feel the constant urge to pee as a result. Also, when the prostate gland becomes enlarged, it increases the chances of that person for prostate cancer. Okay. So NAs can help by providing privacy when necessary for sexual activity, respecting residents' sexual needs, and never judging any sexual behavior unless it's harming another resident or a staff member or visitor. And also keeping in mind that sexual behavior that seems inappropriate should be reported as it could be a sign of illness. Like, say, for example, if the person has a sexually transmitted disease, it might actually, when the infection actually gets to their brain, they might actually start exhibiting inappropriate sexual behavior. Or if the person is mentally ill, then they could also show inappropriate sexual behavior. Okay, so anytime that you notice any inappropriate sexual behavior, tell the nurse if you're working in a healthcare facility, both for the safety of the other residents and also the safety of all of the staff. Okay. And also, of course, for the sake of the patient. So that way we can notify the doctor and find out what's causing them to act that way. Okay. All right. It is important to observe for and report the following: any discomfort or difficulty with urination, discharge from the penis or vagina, especially if it's an older person and they suddenly, like if it's an elderly female, she's already 60 years or older, and she still, if she has any blood that from her vagina or then yeah, that's unusual. Okay. So you need to notify the nurse. Or if they have a lot of vaginal secretions, especially if it smells unusual, or it has an unusual appearance to it, then they might have a vaginal infection. So that needs to be notified to the nurse. Or if they have any unusual penile drainage, uh, like if there's like yellowish pus coming from their penis or anything like that, then yeah, they might have a sexually transmitted disease or they might have a urinary tract infection. We don't know until you report it to us. Okay. Any swelling of the genitals, blood in the urine or stool, breast changes, lumps or discharge, or if you're taking care of a client or resident and you notice that their nipple, whether they're male or female, if their nipple has any changes to it, if it becomes larger than usual, or if it actually inverts or okay. So for most people, the nipple is points outward. Okay. There are some instances though where the nipple is pointing inward. Okay. If the nipple changes in its appearance from an outie to an innie, then you need to report it to the nurse. It might be actually a sign of breast cancer. Or if they usually have an innie nipple, which is typical for most males, and it becomes an outie, then yeah, they might actually have breast cancer and not even be aware of it. Okay. You might think that only females get breast cancer. That is fallacy. That is false. Men can also get breast cancer. Okay. So that needs to be reported to the nurse if you notice any changes in their nipples. Okay. Or any in their breast tissue. So while you're helping them to take a shower or a bath, if you notice that they have any unusual lumps on their chest area or on their armpits, then you need to notify the nurse. It might be cancer. Okay. Or it might be simple inflammation, but we don't know until the doctor does further tests. Okay. Also, if they have any sores on their genitals, like if they have pimples or anything like that down there, redness or rash on the genitals, genital itching, reports of erectile dysfunction. So with erectile dysfunction, if the man can't maintain an erection during sex, that's what we call erectile dysfunction. Also, any reports of painful intercourse. So just remember that residents have the right to sexual freedom and expression, and they have a right to privacy and to meet their sexual needs. Yeah, not the meet, but to meet. That being said, of course, you make sure that you follow your facility's policy and procedure regarding that. Give them privacy, close the door, put a sign on the door if they need that kind of privacy or not. And don't say that, oh, they're a pervert because maybe they're masturbating. No, that's normal, okay, for most people. So, just need to make sure that they're not exposing themselves to other people. If they are exposing themselves to other people, then yeah, that is inappropriate behavior and needs to be reported to the nurse. Okay. All right, so we have vaginitis. So some facts about vaginitis. It's caused by bacteria, protozoa, fungus, or hormonal changes after menopause. Symptoms can include change in color, odor, and amount of vaginal discharge, itching, and burning. So typically with vaginal discharge, it is clear to whitish in appearance, and depending on the time of month the for the woman, it might be either watery in consistency, almost like a gel, or it might be thicker in consistency where it's almost sticky like glue. Okay. So, and then usually the odor of a woman's discharge should smell almost like seawater or salty. Okay. But if it has an unusual odor to it, it smells like spoiled milk, or it smells like fish sauce, or it smells really sour. That might be an indication that they have a fungal infection or vaginal infection. Okay. And so that needs to be informed to the nurse if you're working in a healthcare facility, or if you're working in your family's care home, then notify the care home operator. Okay. Also, if they have an increase in discharge, whereas usually they don't have anything, then that in itself might also be something unusual and needs to be reported to the nurse. Okay. So treatment would include oral medications or vaginal creams or suppositories. So let me close these pictures. Okay, so we have vaginal creams or suppositories that might be ordered by the doctor for that individual to treat their vaginal infection. With the vaginal cream or suppository, it typically comes with an applicator like this one. So you're going to put the suppository inside of the applicator, or put the cream inside of the applicator. You're going to fill it up, and then you're going to insert it into the resident's vagina, and then yeah, remove the applicator, wipe any lubricant or cream that is on the outside of their vagina, and then help them to put on their underwear or their incontinence briefs back afterwards. Okay. So if you're working in a long-term care facility or assisted living as a nurse aide, you are allowed to give vaginal creams or suppositories with a person accompanying you or acting as an observer. Okay. You're not going to do, you're not going to give them the vaginal cream or suppository by yourself. You have to always have a second person with you, and always make sure that when you're charting that you gave the suppository, the vaginal suppository or cream, you documented that who was there with you at the time, like say another nurse aide. Okay. Yeah. So you can do that in the long-term care or assisted living facility, but always have a second person with you. So that way, if the resident accuses you of sexual abuse, you can tell them that, no, I have someone who is with me. Okay, so that's why it's very important that you always document and have someone with you when you're going to administer or insert that vaginal cream or suppository. Okay. For those of you who are going to be working in your family's care homes, it's rare that a doctor will order that. Usually they'll just order oral medications for the client. Yeah, we don't typically do that for them. Okay. In the hospital, if the patient requires a vaginal cream or suppository, it's the nurse's job to do it, not yours. Okay. All right, and then we have some facts about benign prostatic hypertrophy, or BPH. It occurs in men as they age, and that's why for men 40 years or older, they need to go for a prostate or rectal exam. The doctor is actually going to feel for your prostate and see if it's enlarged or not. And at the same time, he also might take some swabs while that he's going to take from your rectum, and then he's going to send that to the lab, and they're going to test you for cancer. Okay. Causes can include enlarged prostate can cause pressure on the urethra, which leads to problems urinating and emptying the bladder. Treatments would be either medications or surgery. And men are also at increased risk for prostate cancer as they age. And prostate cancer is usually slow growing and responsive to treatment. So early detection is important. Okay. So if any of the men in this class, if you're 40 or older, you should be going for your routine prostate exam just to make sure that you stay healthy. Okay. I'm not going to talk about or cover sexually transmitted diseases. It's not in your book, so it's not going to be in your tests. And if you ever have to take care of a person who has an active STI or sexually transmitted illness, then make sure that you follow whatever precautions that are ordered by the doctor, whether they're going to be on contact precautions or not. But yeah. Um, and just make sure that, yeah, you use appropriate use of hand washing and PPE anytime that you're going to help that person to the bathroom for your own safety. Okay. So remember these points about the immune system. Non-specific immunity protects the body from disease in general, and specific immunity protects the body against a particular disease invading the body at a given time. So with non-specific immunity, that is part of our immune system. It includes white blood cells. Okay. So with white blood cells, they actually circulate in our bloodstream, and anytime that they sense any germs or within our bloodstream, like say if you got a cut, then they're going to go to that wound, and they're going to fight off any germs to hopefully help prevent any infection from happening. Okay, that is non-specific immunity. All right. With specific immunity, typically we'll develop it when we have been vaccinated or immunized against a particular disease or illness. Like say, if you've gotten your measles, mumps, and rubella vaccination or MMR shot, then yeah, you're protected against measles, mumps, and rubella. Or if you've gotten your hepatitis B vaccination, then your body is going to produce the necessary antibodies to help fight off hepatitis B. Okay, that is specific immunity. Okay. All right, and then we also have the lymphatic system. Its functions are to remove excess fluids and waste products and to help the immune system fight infection. It is closely related to the circulatory system because lymph fluid, after being purified in the lymph nodes, flows into the bloodstream, and it has no pump but is circulated by muscle activity, massage, and breathing. So with lymph nodes, they're actually scattered all throughout our body, but the largest amount of lymph nodes or locations where you can find them are over here on your sides of your neck, on your armpits, along your upper chest, and on your abdomen and groin. Okay, so that's why when you go to the doctor and you complain about feeling sick, in addition to listening to your heart and lungs, some doctors will also feel your neck and your armpits, feel on your chest, and even push on your belly. What they're doing is they're actually feeling for any enlarged lymph nodes. Because if those lymph nodes are enlarged, then it means that your body is trying to fight off an infection. And it gives the doctor a better idea of what possible illness that you might have, in addition to the signs and symptoms that you mentioned to them during the doctor's visit. Okay. So normal changes of aging to the immune and lymphatic systems include the following. A weakened immune system increases risk of infections. It takes longer to recover from an illness. Also decreased number and size of lymph nodes and decreased response to vaccines. And that's why it's very important that for our elderly residents, those who are 50 or older, they get their booster shots for certain vaccinations. Okay. So that would include getting their annual COVID shot, flu shot. If they haven't already received their RSV shot, now a lot of people, if they're 50 or older, especially if they have pre-existing health conditions like diabetes or hypertension or heart disease, that they get their RSV shot also. Okay. Also, they need to get their tetanus shot or booster every 10 years for all adults. MMR shot if they're 68 years or younger. Okay. If they're 69 years or older, yeah, they don't need to take the MMR. Usually, most people who are older than 69 years old, they've already actually developed immunity to measles, mumps, and rubella. Okay. Shingles vaccination if they're 75 years or older, and also their pneumonia shot or pneumococcal vaccine. Okay, so those are all vaccinations that people who are 50 years old or older should get vaccinated for, because that's when your immunity starts lowering. Okay, or they no longer have the necessary antibodies to fight off those illnesses. Okay. So NAs can help by washing hands properly and keeping the resident's environment clean to help prevent infection, and encouraging your resident to also wash their hands anytime they use the bathroom or before they eat. Assisting with personal hygiene as needed, encouraging proper nutrition and fluid intake, and measuring and reporting vital signs accurately to detect possible infection. So again, vital signs are temperature, pulse rate, respiratory rate, and blood pressure. Okay. And so it is important to observe for and report the following: recurrent infections, if they get sick all the time, swelling of lymph nodes, and increased fatigue. So we also have HIV as one of the immune system diseases. We're on page 111. So, acquired immune deficiency syndrome or AIDS is caused by the human immunodeficiency virus or HIV. HIV attacks the immune system and disables it, and AIDS is the final stage of HIV infection in which infections, tumors, and central nervous system symptoms appear. So that's when the HIV is already attacking the person's nervous system, including their brain. And that's when they're more likely to actually get more infections and or actually show signs of dementia or confusion and forgetfulness. And usually that's when we already know that they're close to dying. Okay. They're close to death. So HIV is transmitted by sexual contact, blood, and infected needles. Symptoms at transmission or when the person first gets infected are like the flu, and later symptoms include infections, tumors, and central nervous system symptoms. Late stage is AIDS dementia complex. Or like I was saying, it's affecting their brain already. Signs and symptoms of AIDS include the following: flu-like symptoms, appetite loss, weight loss, night sweat, swollen lymph nodes in the necks, underarms, or groin, severe diarrhea, dry cough, skin rashes, painful white spots in the mouth or on the tongue. So when you're taking care of someone and you notice that they have white spots on their palate, the roof of their mouth, or on their tongue, yeah, this is a fairly big picture. On their tongue or on their gums, tell the nurse as soon as possible. This actually shows that they have a fungal infection in their mouth. And if the fungal infection gets into their bloodstream, particularly if it gets to their heart, then that infection will be difficult to treat and that they could potentially die as a result. So we want to treat it while as early as possible. So once you start seeing those white spots in their mouth, tell the nurse. Even if it's just one white spot, better that you point it out to the nurse and they get treated for it versus waiting for it to spread into their bloodstream. Okay. Cold sores or fever blisters on the lips and flat white ulcers in the mouth. So if they have any ulcers like this one, or blisters on their mouth or lips, then yeah, you need to also tell the nurse and make sure that you use gloves anytime that you're going. Well, you should be using gloves to begin with. But yeah, use extra caution whenever you're handling anything that the person has used to wipe their mouth, because this is contagious. Okay. Yeah. This is actually caused by the herpes zoster virus, and it's highly contagious. And yeah, you don't want to come into contact with any of the drainage from those blisters or any blood or that comes from those blisters. You could get infected easily. Okay. So make sure that you use your PPE and wash your hands after helping the person who has this. Okay. If they have warts on the skin or in the mouth. So warts are abnormal skin growths that you might notice on their skin. So this is an example of a wart. It looks like kind of like a broccoli skin growth on their skin. That's what we call a wart. Okay. This is also caused by a virus. And so, yeah, a person who has HIV is more prone to developing warts in addition to the others. They also might have inflamed and bleeding gums, bruising that does not go away, low resistance to other types of infection, Kaposi's sarcoma, which is a type of skin infection, skin cancer. So with Kaposi's sarcoma, typically it'll form reddish or reddish to bluish type, almost like blood-filled, uh, blisters on the skin, just like what's shown out here on your screen. It's typically located on the upper shoulders, on their arms, and on their face. So if you notice that they have any, it almost looks like a bruise in some cases. So if you notice anything like that on your client or on your resident, please tell the nurse as soon as possible. So that way we can inform the doctor and get that person tested. That being said, if the person does have Kaposi's sarcoma, it doesn't necessarily mean that they have HIV. Okay. A person can get Kaposi's sarcoma as a skin cancer, period. It doesn't necessarily mean that they have HIV. All right. It might just be that they have skin cancer. Pneumocystis jirovecii pneumonia, which is a type of lung infection, and AIDS dementia complex. So just remember that opportunistic infections invade the weakened body, worsening AIDS. And treatment is medication. Drugs slow the progress, but there is no cure for the disease. There's no vaccine for HIV either. Okay. So when the person has HIV, typically, if the person has HIV, they will be taking HIV medications. Okay. If the person is going to be in a sexual relationship with someone who has HIV, that or then they might be placed on what we call the PrEP pill regimen. So PrEP stands for pre-exposure prophylaxis. So they would take that before HIV exposure. So it's typically taken routinely anytime that they're having sex, if they are a drug user, or anytime that they might be exposed to HIV routinely. So that's to help prevent them from getting HIV. And the PrEP pill regimen is 99.9% effective in preventing HIV. Okay. If the person already has HIV, or if you have been exposed to HIV, like if you're going to be working in a healthcare facility, and you're taking care of someone who is HIV positive, and you got splashed or sprayed with their blood or other body fluids, then you're going to take PEP pill. Okay, so PEP stands for post-exposure prophylaxis. So in emergency situations where you have been exposed to an HIV positive person's blood or other body fluids, you need to start the PEP pill regimen within 72 hours of exposure. And then you're going to take it again about a month afterwards, just to make sure that any HIV that might have been introduced into your body is killed off, okay, before you actually get infected. If you wait more than 72 hours after exposure, then the medication is not going to be effective. You're not going to be protected against HIV. You could easily get infected. Okay. So, um, if the person is already HIV infected, okay, either from having sex with someone who is HIV positive, or maybe from drug use or other HIV exposure, then they might have to continue taking PEP pill regimen for the rest of their life to help to maintain or keep the HIV virus numbers low within their body system. Okay. So yeah, just remember that anytime that you've been exposed to blood or other body fluids, especially if there's a high chance that the person is HIV positive, or if they do test positive for HIV, then you need to take the PEP pill regimen within 72 hours after exposure. Otherwise, you could easily get infected. Okay? So again, with the PEP pill, just like with the PrEP pill, it's 99.9% effective if it is taken within 72 hours after you're exposed. Okay. All right, so care guidelines for HIV or AIDS, follow standard precautions and transmission-based precautions if ordered. Residents with poor immune systems are more sensitive to infections, so make sure to wash your hands often and keep everything clean. Also encourage your resident or patient to also wash their hands frequently, especially before they eat or after they've touched any high contact items like doorknobs, curtains, call light, okay, or if they've touched any walls or like the elevator buttons within the facility or hospital. Okay. High protein, high calorie, high nutrient meals can help maintain a healthy weight. Oh, by the way, we're not having them wash their hands or use hand sanitizer after they touch the high contact items to prevent them from spreading HIV. It's to help prevent them from getting infected by whoever's germs was left over on those objects. Okay. So it's to prevent them from getting sick, not from them spreading the HIV. Okay. Because the HIV is not going to be on their hands. Not unless they've jerked off before they went out of the room. Okay. But yeah. Where we want to protect them instead from getting infected from whatever germs might be on those surfaces. All right. Uh, High protein, high calorie, and high nutrient meals can help maintain healthy weight. So you might, when you're working later on, um, especially if you're working in a healthcare facility, we have a lot of different types of supplements that we can offer to the patients or residents. Make sure that you double check first with the nurse before you offer any of the supplements that are in the nourishment refrigerators within the facility. Don't just automatically give it to them. Unless it's written in the care plan, yeah, we don't usually just hand out these things to them. Okay. These are only offered if it's in the care plan or under the doctor's orders. Otherwise, we'll just offer them other beverages that are available within the nourishment room. Okay. So we have Boost, we have Ensure. Nowadays, Ensure doesn't just come in the milkshake, which most people are most familiar with. There's also Ensure Clear nowadays, which is actually like a juice type form, and it comes in different flavors. There's apple juice, there's raspberry, raz, or something like that, mixed berry. And so, depending on what's available within your facility, you can offer that to the patient or resident. Again, make sure that you check with the nurse first before offering any of these supplements, especially if they eat 75% or less of their meals. We also have supplements that are in pudding form. Where are you, pudding? Okay, I guess I didn't open it. But yeah, it also comes in pudding form. So we also have Boost or Ensure pudding. And then we also have Glucerna for those residents or patients that are diabetic. Okay. Some people with HIV or AIDS lose their appetite. Help make meal times pleasant and relaxing and know the residents' favorite foods. Notify the nurse of appetite loss or difficulty eating. So if the person has severe appetite loss or difficulty eating, oftentimes the doctor might order for a dietitian to uh, dietitian consult. So that way the dietitian can find out what foods that the person likes and then make a custom meal plan for that individual if they don't already have one. And the doctor might also order for that patient or resident a appetite stimulant. Okay. And in some rare cases, the doctor might even prescribe for that individual medical marijuana. So with medical marijuana, the person can go and smoke it outside in the designated smoking area. And what the medical marijuana does for someone who has HIV is that it both stimulates the appetite and it also helps to relieve any pain that they might be experiencing related to the HIV infection. Okay. If residents have infections in their mouth, they may need food that is low in acid and spice and neither cold nor hot. So like if they have any lip sore, mouth sores, or any white sores inside of their mouth, then yeah, we might want to notify the nurse and check and see if we can offer other foods for that person and then make the necessary dietary requests to the dietary department if you're working in a healthcare facility. Okay. Make sure that you follow your facility's policy and procedure regarding that. Okay. Liquid meals and fortified drinks may help ease the pain of chewing. So again, we might offer them Ensure or Boost or Glucerna, depending on the situation and per the care plan or doctor's orders. And warm rinses may help painful mouth sores. So we might give them we might use a warm water with some salt mixed in, so a salt water solution, for them to gargle with. That will actually act almost like a moisturizer, inside of their mouth. It actually relieves pain. You might be like, oh, wouldn't that be sore? If they have mouth sores, it actually feels really soothing for most people. Not unless that thing, the sores inside of their mouth are bleeding or open, then yeah, that is, you do not want to give them a saltwater gargle or rinse. So, we can also give them a baking soda gargle. So you would add 1 teaspoon of baking soda to 8 ounces of warm water and then have them gargle with that. And again, that helps to actually soothe the irritated areas inside of their mouth. Don't do that though, unless it's been okayed by the nurse or by the doctor. Okay, and give careful mouth care. In a lot of instances, a toothbrush might irritate their gums or lips even more. And so instead of using toothbrush, even a soft bristled one, we would use the oral swab instead and just put the toothpaste directly onto that oral swab. Or if the toothpaste is too irritating for their gums or mouth, then instead of using toothpaste, we would use baking soda on the oral swab, or just wet the oral swab as is and use that like a toothbrush to clean their teeth and gums. Okay. Small frequent meals can help with nausea, and high fat and spicy foods should be avoided. Eating a soft bland diet may help and help ensure proper fluid intake. So when you know that the person is nauseous or vomiting, they should avoid anything that is going to further irritate their stomach and cause them to throw up even more. So avoid high fat and spicy foods. Also, we typically we would avoid also dairy, especially if the person is lactose intolerant. Okay. We might ask if the person can have broth instead of coffee or tea served with their meals. And then we might also ask if from the dietary department if they have juk or porridge available that we can serve to that person. And then with the okay of the nurse, of course, or per the care plan. And then you can also ask dietary department if we can have some extra portions of that rice porridge or juk available to keep in the refrigerator. So anytime that patient or resident feels hungry, we can just heat it up in the microwave and serve that to them. Okay, together with some broth. Or we would also keep crackers available. So anytime that person is feeling nauseous, we can give them those crackers instead, together with some flat soda. When I say flat, we actually let it sit for a while so that way the carbonation doesn't make them even more nauseous. Okay. Um, that will actually help to relieve their feelings of nausea in most cases. And then if diarrhea is severe, doctor may order brat diet, bananas, rice, applesauce, or toast. This is helpful short term. So typically that's only going to be ordered for about 24 hours. If they're still experiencing diarrhea after 24 hours, then just inform the nurse if that person is continuing to have diarrhea. So that way we can do further testing or assessment of that individual. They might have a intestinal infection. Good rehydration fluids include water, juice, caffeine-free soda, and broth, and you want to avoid any caffeinated beverages or food. So examples of caffeinated food includes chocolate. Okay. So yeah, you're not going to serve them anything that has chocolate or coffee, obviously, added in, like tiramisu. Yeah, they can't have tiramisu, obviously, because it has both chocolate and coffee in there. Neuropathy, numbness, tingling, and pain in the feet and legs is usually treated with medication, and wearing loose, soft slippers may help. A bed cradle may be used to keep sheets and blankets off the legs and feet. So with bed cradle, okay, this is another picture of a oral swab. Bed cradle is basically a plastic or metal frame that goes over the foot of the bed, and then you're going to drape the blanket over it. Okay, so in this picture, they show that the person's feet and legs are exposed, but the blanket can actually be lowered until it's completely covering the person's feet. Just make sure that the blanket isn't actually touching any part of their legs, okay, when you're using the bed cradle. That helps to lessen the feeling of neuropathy that the person is experiencing. Because sometimes just the weight of the blankets alone on top of their feet can irritate them and be very uncomfortable. Okay. Residents may experience anxiety and depression, and treat them with respect and provide emotional support. So with a lot of people who are HIV positive, they feel ostracized, or they feel that they're being discriminated against because of their HIV positive status. Okay. So just remember that no matter what the person's illness or disease, we treat them the way that they want to be treated. You need to treat them with respect and give them some dignity. Okay. Um, so yeah, if they're experiencing or verbalizing any anxiety or depression, make sure to tell the nurse if you're working in a healthcare facility. And if you're working in your family's care home, then you need to notify the care home operator so they can mention it to that person's doctor when they go for their routine visit. If they're expressing any depression and also any feelings of wanting to hurt themselves or other people, then take it seriously. Remove any items that they could potentially use as a weapon to harm themselves or hurt other people. Okay, so any sharp objects, take it away. and also keep a close eye on them to make sure that they don't actually try to carry out their threats of wanting to commit suicide. All right. And also provide a safe environment and close supervision of ADLs, especially once their health starts deteriorating and they're going to become more dependent on us as their caregivers in providing their care. Okay. Um, they're going to become weaker and eventually totally dependent on us for all of their ADLs. Also, remember that AIDS causes a great deal of emotional stress, and NA should be sure to provide emotional support and encouragement to residents with AIDS, just like I was talking about a while ago. Also, remember that a resident's HIV or AIDS status is confidential and it cannot be discussed with anyone. Just like with any other illness, we cannot tell any other people other than the people who are going to be directly involved in that person's care that that patient or resident is HIV positive. Okay. You can't tell anyone else that they are HIV positive. You can't even tell their roommate, if they have a roommate, that that person is HIV positive. Okay. Violating this confidentiality is not only unethical, it is a violation of the law. All right. So yeah, don't assume that just because a person has HIV that they're a druggie or that maybe they were sexually promiscuous or anything like that. Yeah, you don't know their history. You don't know how they got infected with HIV. In my years working as a nurse, I've actually taken care of several HIV positive patients, and a couple of them were actually former nurses. And like for one, she got infected because she received a blood transfusion back in the 1980s when they didn't test for HIV in blood, donated blood. And so, yeah, that's how she got infected. She was in a car accident and she needed emergency blood transfusion as a result. And that's how she got infected. So it's through no fault of her own. Another lady, she got infected because of her husband. He was cheating on her. He liked to visit prostitutes, and that's how he got infected. And then he infected her as a result. So it's through no fault of her own either. So don't automatically assume that they deserve what they got. Okay. Don't think that just because they're HIV positive that they don't deserve any care or that you should treat them any differently than anyone else. Okay. So you don't know how they got sick. All right, now we're on cancer. So we have the following key term. Tumor is a cluster of abnormally growing cells. And some facts about cancer. General term used to describe a disease in which abnormal cells grow in an uncontrolled way. Tumors can be benign or non-cancerous and usually grow slowly, or malignant, where it's cancerous and can grow rapidly. There is no cure for cancer. Typically, when the person receives treatment, they can go into remission or have the cancer cells be killed, but they can always come back again. Okay. And so cancer can also spread to other areas of the body or metastasize, affecting other body systems, and often first appear in the breast, colon, rectum, uterus, prostate, lungs, or skin. So the following are known causes of cancer. Genetic factors. If you have any family members, immediate family members that have had cancer, your chances for developing cancer in the future are much higher than a person that doesn't have any family history at all of cancer. Okay. Tobacco use, alcohol use, poor diet, obesity, lack of physical activity, certain types of infection. Like if the person has HIV infection, they're at increased risk for developing Kaposi sarcoma. Okay. Also, environmental exposure such as radiation. And that's why, like in the hospital, those people who work in the in the radiology department, a lot of them actually wear special badges that will alert them when they've been exposed to to high amounts of radiation. And so, yeah, they'll be told that, okay, you can't go into that room anymore where the x-rays are being taken. Otherwise, it increases their chances of developing cancer in the future. Okay. Also, sun exposure can increase your risk for cancer, especially skin cancer. All right, and the following warning signs of cancer are identified by the American Cancer Society. Unexplained weight loss, fever, fatigue, pain, skin changes, change in bowel or bladder function. If they used to be regular, pooping once every 3 days, and now they're pooping more frequently, or they're peeing more frequently, there's blood in their stool, it might be a sign of cancer. It might be not. We don't know until the doctor does further tests on them. Okay. Sores that do not heal, unusual bleeding or discharge, thickening or lump in the breast or other part of the body, indigestion or difficulty swallowing, recent change in a wart or mole. Where's my picture of that? So, like, if these are examples of moles or birthmarks. If there's any changes in the color, in the borders, or in the appearance of the mole or birthmark, then it might be skin cancer. Okay. Nagging cough or hoarseness might also be signs and symptoms of cancer. Okay. And so we also have different treatments for cancer. It says three, but there are actually five. Let me go over here to my. Okay. So nowadays there's actually seven potential treatment options for cancer. Okay. We have surgery where they remove as much of the cancer or tumor as they can, as a surgeon can. We also have chemotherapy where they receive specific anti-cancer drugs to kill the cancer cells. We have targeted therapy, which is similar to chemotherapy, in which they receive anti-cancer drugs, but with targeted therapy, it destroys the preferred environment of that the cancer cells like to grow in, or it destroys a particular protein or gene of the cancer and helps to prevent the body from producing additional cancer cells. Okay. We also have radiation therapy where it uses X-ray-like waves or therapy to actually shrink or destroy the cancer cells. We have immunotherapy, which uses certain medications that help to boost the person's immune system to help to fight the cancer cells. And then the one that's not mentioned in your book are bone marrow transplantation, where like if the person has leukemia or um, the cancer is actually affecting either their bone marrow or their blood, then a bone marrow transplant of healthy bone marrow will help their body to produce healthy blood cells instead of cancer cells. Okay. And the last one is hormone therapy, especially if in female type cancers like breast cancer or uterine cancer or my brain just went blank. Ovarian cancer. So in those three types of cancers, the woman might receive, in addition to chemotherapy or targeted therapy, hormone therapy, because with certain types of female cancers, um, with certain high numbers or large amounts of hormone therapy, it can actually make the cancer cells not grow. Okay. It creates a hostile environment basically. And so the cancer cells will find it difficult to be produced within the body. Okay, so these are all different types of cancer treatment options that you might see or hear about in the future when you're working with anyone who has cancer. Okay. Okay, so care guidelines for cancer. Each case is different. Do not make assumptions. Like, say, for example, if you're taking care of two different patients who have breast cancer, don't assume that they're the same. No, when they're being treated. No, it all depends on what stage of breast cancer that they have and whether it is benign or if it's malignant. If it's benign breast cancer, then yeah, that person, um, they don't, typically depending on how big the lumps are or how many they are, the surgeon might decide to just remove the lumps and then conservatively also treat them with chemotherapy drugs just to be on the safe side. But if they have malignant cancer, yeah, then the doctor, in addition to doing surgery, will be a little more aggressive in treating the cancer. Okay. So obviously that person is going to need more care and assistance than the person who has benign cancer. Okay. Respect the residents' needs and be honest and sensitive and have a positive attitude. So depending on how the person reacts to their cancer diagnosis, we're going to be supportive to the extent that they need. So if they don't want us like talking to them, but just helping them out, and when I say talking to them, like asking them to open up to us about any concerns that they have. Some of them, they'd rather not talk to the staff. Okay. Others, because they don't feel comfortable talking to their family about their diagnosis, they feel more comfortable talking to the nursing staff instead. So it all depends on the individual. So if your patient wants to talk to you about their cancer diagnosis, just listen. And if you don't know what to say, then let them know that, okay, you're going to let the nurse know about their concerns if they have any. Otherwise, just being there and listening to them, giving them a pat on the shoulder, or holding their hand sometimes can be more meaningful than, you know, just saying whatever to them. Okay. So, if you don't know what to say, just be silently supportive by, again, giving them a pat on the shoulder, a hug, a one-armed hug, or holding their hand can mean more for most people. Okay. Also encourage a variety of food in small portions. Try plastic utensils for residents receiving chemotherapy. If you know that your patient just received chemotherapy or immunotherapy drugs, then make sure that you give them plastic utensils with their meal trays. Dietary department won't know, so it's up to us as the nursing staff to switch out their utensils with plastic ones instead. If Otherwise, if the patient who just got chemo uses any metal utensils, they're more likely to become nauseous and throw up and create more work for you. So always remember to switch out their utensils with plastic ones. Okay. Watch for signs of pain and report them to the nurse. Help with comfort measures such as repositioning and providing comfort, conversation, music, or reading materials. So when I used to work in the hospital and I take care of cancer patients, I try and connect with them or find out what their likes or dislikes are. And then if they had any hobbies or likes that, I enjoyed also, like video games or reading, then yeah, that I would talk to them about the stuff that um those kinds of things, and that helps them to feel more normal. Okay. And it also helps them to get their mind off of their cancer diagnosis and focus instead on things that they enjoy. So that's something that we can do as nursing staff. All right. Also offer back rubs for comfort and to increase circulation. If they're receiving If they have just had surgery or if they are receiving radiation therapy, please do not give them a back rub because their skin is going to be very sensitive. And yeah, you don't want to give them a back rub because then you might cause them further discomfort. Okay. Use lotion on dry skin, but do not remove any markings, especially if they're receiving radiation therapy. Actually, if they're receiving radiation therapy, the radiologist is typically going to either use a marker to mark the spot on their body where they're going to target the radiation, or they might also use little plastic or paper dots on their skin. If you notice anything like that on on your client or resident, please don't take them off. Okay, they're on there for a reason. The radiologist will place them there to help serve as a reminder of where they're going to target the radiation on that person's body. All right. And then if they're receiving radiation therapy, they should not be using any personal hygiene products like lotion, cologne, or perfume, any powder or makeup. They shouldn't be using any deodorant. Okay. Because those can all either block or interfere with the delivery of the radiation therapy to that person's body. Okay. Um, Not only that, but the those personal hygiene products can also interact with the radiation and cause a chemical burn, okay, or radiation burn on their skin. And so that's why we don't use it. Okay. Um, Even with the soap or body wash that they're going to use, it should be unscented or fragrance free. They shouldn't be using anything that has any fragrance on it because then again, it's going to interact with the radiation and irritate their skin further. All right. Let's see. Help residents with oral care often. Use a soft bristle toothbrush and baking soda or other prescribed rinse. So depending on the doctor's order or the care plan, make sure that you notify the nurse as needed if the person's mouth is very sensitive, especially their gums, with chemotherapy or with the radiation therapy. And sometimes, like I mentioned, also with HIV patients, instead of using a toothbrush, we might just use an oral swab instead. Okay. Also, don't use any strongly flavored toothpaste for brushing their teeth. Instead, just that's why in the hospital, the toothpaste that we have on stock is usually you can barely smell any like any mint flavor or mint fragrance to it. That's because it's very mild. That's to help prevent irritating our patients' mouths when they do need to brush their teeth, okay, or clean their mouth, okay? So make sure that you only use whatever you have within the facility. And if they have any mouth irritation, then obviously tell the nurse. Assist with grooming if desired. So oftentimes, especially when the person is receiving chemotherapy drugs or immunotherapy drugs, their hair will fall out. And so that can actually be very disconcerting or concerning to a lot of patients that even when they know that they're going to lose their hair, sometimes they can't deal with it. Okay. And it's not just their hair on their head that they're going to lose. All of the hair on their body is going to fall out. Yep. Even their eyebrows, even their eyelashes, even their pubic hair, and all of the other body hair, it's gonna come, they're gonna lose it with certain chemotherapy drugs. Okay. So if the person wants help in either putting on false eyelashes or maybe drawing eyebrows or putting on a wig or covering their scalp because they're balding or they have bald patches, covering their hair or their scalp with either a wig, a hat, a scarf, or a do-rag or anything like that, then help them do so. If you don't feel comfortable in helping them to put on makeup, then ask someone else on your unit uh, or to help that patient, okay, or resident. All right. But yeah, we want to help them to feel more normal as much as possible because then they're going to be less likely to get depressed. Also, we want to make sure that they cover up if anytime that they're going to be going outside or exposed to any sunlight for more than direct sunlight for more than 15 minutes. Because with certain chemotherapy drugs, and especially if they're receiving radiation therapy, they're not going to be able to tolerate sun exposure. Okay. They're going to get sunburn easily. And so, yeah, they need to cover up. So they need to wear a hat or some other head covering. They need to wear sunscreen or long sleeve shirt and or an umbrella to protect their skin if they should go out in this or be exposed to sunlight. Okay. All right, I'm going to stop there. It's 11:30. Go ahead and take your 15-minute break if you want to. Thank you. And we'll continue at 11:45. All right, let me just make this bigger. Okay, and then also encourage visitors and suggest good times of the day for visits and get to know the residents' interests. So for that one, especially if you know that they are receiving chemotherapy drugs or radiation therapy, right after the person receives their chemotherapy, oftentimes they're going to feel nauseous and might even throw up, or they might also feel weak or lightheaded. With radiation therapy, they're going to be either very uncomfortable or in a lot of pain, depending on um, the location of the radiation therapy. So if you know that that person just received their treatment, then let their visitors know what would be a better time for them to come and visit. Like, say, for example, if they're receiving chemo, then we would encourage most visitors to come maybe 2 to more hours after their treatment before the next treatment that they're going to receive that day. So that way they're more able to actually appreciate the visit from that visitor, and they're going to be less nauseous during the actual visit. With radiation therapy, yeah, we would encourage them to um, maybe come in about anywhere between 4 to 6 hours after the treatment, or preferably before they go for the treatment. Again, so that way the patient can enjoy the visit from their family or other visitors, or they can tolerate having them there. Because oftentimes, yeah, they won't feel them in the mood for any visitors after they've received their treatment. Okay, and be alert to unmet needs. So, depending on the individual, they might express to the nursing staff, you as their caregivers, any concerns that they might have. They might oftentimes tell us that they're concerned about their family, how they're going to afford to pay for the medical bills. They might also have concerns regarding transportation or parking, etc. Um, all of those concerns can be informed to the nurse if you're working in the healthcare facility, and then the nurse can then refer it to the social worker. So that way the social worker can see what they can do to actually help meet those concerns that the patient has regarding any of those needs. Okay. So, like, say, for example, if they're concerned about paying the bills and all that, then they might see if they qualify for any financial assistance, or if they're concerned about losing their health insurance coverage, then the social worker can help to see if they qualify for Medicare or Medicaid. And yeah, um, anything else that they need help with, then depending on the availability of resources, the social worker will help them to actually see what they qualify for. Okay. All right, and then the following are signs and symptoms to report when a resident has cancer: increased weakness or fatigue, weight loss, nausea, vomiting, or diarrhea, changes in appetite, fainting, signs of depression, confusion, blood in the stool or urine, changes in mental status. So if they're usually alert and oriented, they know where they are, they know who you are, they know what the date is, and now they're confused about that or forgetful. Yeah, that's a change. So that needs to be informed to the nurse. And we don't know if the cancer is metastasized to their brain, and or there's some other complications related to the cancer or to the treatment they're receiving that's starting to affect their ability to process information. Okay. Any changes in their skin, new lumps, sores, or rashes, increase in pain or unrelieved pain, and blood in the mouth. It might be that the cancer has spread to other parts of the body, or they're experiencing complications related to the anti-cancer treatments that they're receiving. So always make sure to inform the nurse about anything new or different about your patient or resident. Okay. And that is the end of chapter 4. Do any of you have any questions regarding chapter 4? No? Okay. All right. Let's go to chapter 5. Oops. Sorry, I can't see. Here we go. Full screen. Okay. So we have chapter 5, confusion, dementia, and Alzheimer's disease. So we're on page 115. So we have the following key terms. Confusion is the inability to think logically and clearly. Delirium is a state of severe confusion that occurs suddenly and is usually temporary. Like, say, for example, when the person goes in for surgery and they receive general anesthesia, when they come out of surgery until the anesthesia wears off, usually they're in a state of delirium after that. They're confused. They don't really understand what's going on around them. Or if you talk to them, they immediately forget after a minute or two what you actually said to them. So, some points about confusion: it interferes with the ability to make decisions. Personality may change. Anger, depression, and irritability are other signs, and it can be temporary or permanent depending on the cause. So causes of confusion include the following: UTI or urinary tract infection, low blood sugar, head trauma or injury, dehydration, nutritional problems, fever, sudden drop in body temperature. If the person feels really cold, or if they are a victim of drowning incident, they can be confused immediately after the drowning, or until they actually warm up. Okay, so lack of oxygen, medications, infections, brain tumor, diseases or illness, loss or lack of sleep. If the person isn't getting enough sleep, or good quality sleep, then they can end up becoming confused, and also right after a seizure. So, when caring for a resident with confusion, do not leave a confused resident alone. If you do need to leave them alone, like when you're going to take care of your other clients or another resident, make sure that you check on them more frequently. Even just a quick peek in on them while they're lying in bed or while they're sitting in a chair, or put them where you can. Check on them real quick to see what they're doing, and to make sure that they're not trying to get up on their own or wander off where they're not supposed to. Okay. Stay calm and provide a quiet environment. Oftentimes, when there's a lot going on around them, a lot of people or a lot of sounds or other stimuli, it can actually cause a person to become even more confused. So that's why we want to provide a quiet environment as much as possible. Okay. At the same time, though, we want to make sure that they stay again um, within our views so that way we can keep an eye on them and prevent them from getting hurt or doing anything that could end up with them getting hurt. Okay. Speak in a lower tone of voice and speak clearly and slowly. Um, like for me, my voice is actually high pitched normally, but I've just learned to actually lower the tone of my voice so that when I'm talking to my elderly residents or patients, yeah, they can easily understand me. And also, like when I'm teaching Zoom classes, it's easier for you to actually understand me versus when I'm talking in my normal voice. Okay. So, introduce yourself each time you see the resident. Don't assume that they remember who you are. Okay. You always have to introduce yourself every time when you're dealing with someone who's confused. So if you saw them 2 hours ago, don't assume that they still remember you. No, just remind them, "Hi, Mrs. Smith, it's me, Army again. How are you doing?" Kind of thing. Okay. Remind the resident of the location, name, and date. So, in a lot of healthcare facilities, especially in the hospital and in the more well-equipped long-term care facilities, we have whiteboards on the walls. So that way we can quickly update that whiteboard with any pertinent or important information that the patient or resident needs to know. So I'll have on that whiteboard today's date, who are the staff who are taking care of them, what their dietary needs are, what kind of activities that they're supposed to have. Are they allowed to get up out of bed or not? Okay. It'll also have on there any other staff that are helping to take care of them, or any scheduled appointments or procedures that they have. Okay. And then, like I mentioned yesterday, in the long-term care facility, we also have calendars at the bedside for all of our residents, either a regular calendar that has the date on there, and then we just help them cross it off to mark a new day. Okay. And keep track of what day it is, or we'll have the dietary or activity calendar there at their bedside so that way they can keep track of what's being served for lunch and dinner or whatever activities are scheduled for the day. Okay. Let's see. Explain what you're going to do using simple instructions. Be patient and do not rush the resident. Give them enough time to actually do the ADL. You have to remember that with the elderly, they're much slower in doing things and also moving around. And so, yeah, you have to give them more than enough time. What might take you only a minute to actually do, it might actually take them 2 to 5 minutes to complete. So always make sure that you give them enough time. Uh, but at the same time, also remind them what they're supposed to be doing so that way they don't just sit there. All right. Because when they're confused, they forget what they're supposed to be doing. Like even using the toilet. That's why I mentioned before the break that when you're talking to someone who's confused, you need to remind them, right? Mrs. Smith, are you okay there in the bathroom? Are you done peeing or pooping? Okay. That helps to remind them what they're supposed to be doing. Otherwise, yep, they're just gonna sit on the toilet, like just staring into space, not really knowing that they're supposed to be peeing or pooping. Okay. Let's see. Talk about plans for the day and keep a routine. By keeping to a set routine, it helps to give them that sense of security, and it also helps them to know or remember what they're supposed to be doing. So basically a muscle memory. They're so used to getting up at a certain time, eating their meals at certain times, afterwards going to the bathroom or going to activities that they get used to it. And so anytime there's a change in that routine, it can sometimes increase their confusion and upset them, obviously, just like with us. when in our normal routine. If there's any like significant changes to our routines, can be upsetting to most of us. So it's the same thing, especially with the people who are confused to begin with. All right. Encourage the use of eyeglasses and hearing aids so that they can see and hear better. And hopefully, it'll improve communication. Also promote self-care and independence. So let them do what they can for themselves and make choices regarding what kind of ADLs or care that they want to receive. Okay. Also, do not leave cleaning agents or personal care products where the resident can access them. We don't want them to accidentally eat or drink anything that they're not supposed to, or come into contact with anything that they're not supposed to. Like when I worked in long-term care, the first facility that I worked at, one of my residents actually liked to eat wipes. And so we would not leave any kind of cleaning products at her bedside, even personal care products. Actually, she eventually got into the habit of eating anything made of paper, and so even her pictures at the bedside, we would make sure that she couldn't reach for them. Otherwise, she'd take them out of the picture frames and try and eat them. Okay, so yeah, that's something that you just need to be aware of. And also report any observations or changes to the nurse. So anything new or different about that person, like say if their confusion is getting worse and they're more forgetful, then tell the nurse. We might need to update the care plan, especially if that person requires more assistance or care in their daily activities. All right, causes of delirium include the following: infections, disease, fluid imbalance, poor nutrition, drugs, and alcohol. So, yeah, those are the ones that I don't enjoy. When we have the really drunk patients who are admitted into the unit and they're also having seizures at the same time, those are not fun. Okay. But yeah, they can experience delirium. Okay. As a result. So these are all symptoms of delirium: agitation, anger, depression, irritability, disorientation. So they are confused about person, place, and time or date, trouble focusing, problems with speech, changes in sensation and perception. So they might experience hallucinations or delusions. They might tell you that, oh, they have ants or other insects crawling all over them. They might tell you that they're seeing dead people or ghosts, or that they have been abducted by aliens and that's how they ended up in the state that they're in. Okay. So those might be, you might notice that in people who have delirium. They also have changes in consciousness where it's difficult for you actually to wake them up or get them to respond to any questions that when you're talking to them. Okay. Also, they'll have a decrease in short-term memory, so their ability to remember recent events. So when they're delirious and you just told them who you are, right after you finish talking to them or telling them who you are, they'll ask you, "Who are you again?" So yeah, those are not fun when you're dealing with those kinds of patients or residents. But that being said, you need to remember to be patient and understanding. They can't help being the way they are, right? So just remember that it helps to be gentle and to keep one's voice low when communicating with someone who is confused or disoriented. Use the person's name and speak clearly using simple sentences and reduce distractions as much as possible. So either turn off the TV if the TV's on, or turn off the radio or lower the volume on it so that it's not distracting the person while you're trying to talk to them and explain whatever it is that you're going to do with them. Okay. Also get into the habit of learning how to repeat yourself word for word at least twice, like I mentioned back in chapter 2, and then changing it to a more simple question the third time around. Also getting into the habit of saying the person's name twice or every other sentence. So an example of that is, "Good morning, Mrs. Smith. My name is Army. I'm your nurse aide today. Mrs. Smith, I'm here to give you a bed bath." Okay. If they don't respond, then you say it again word for word. Or if they just stare at you, then you're going to say, Mrs. Smith, I'm going to give you a bed bath. Okay. So every other sentence, you're going to say their name. What that does is it actually helps to grab their attention so that they focus on you and hopefully listen to what you're saying to them. Okay. All right, and then we have the following key terms. Cognition is the ability to think logically and clearly. Remember that that's going to be in your test. Cognitive impairment is loss of ability to think logically and clearly. Dementia is a serious loss of mental abilities such as thinking, remembering, reasoning, and communicating. That's also going to be in your test. Alzheimer's disease is a progressive incurable disease that causes tangled nerve fibers and protein deposits to form in the brain, which eventually causes dementia. Okay. Remember that that's also going to be in your test. And remember that dementia is not a normal part of aging. Okay. So the following are common causes of dementia. You don't have to remember these. Alzheimer's disease, multi-infarct or vascular dementia, which is a series of strokes causing damage to the brain. So yeah, when a person has had a stroke, they're more likely to develop dementia later in life. Also, Lewy body disease, Parkinson's disease, and Huntington's disease. Lewy body disease and Huntington's disease are genetic diseases that a person as one of the complications related to disease can develop dementia as a result. Okay. Diagnosing dementia is a complicated process. It involves getting a patient's medical history and having physical and neurological exam. Blood tests and imaging tests like CT or MRI scans may be ordered, and tests to trace brain wave activity or like EEGs may be performed by the doctor. And a diagnosis of dementia helps to rule out other possible diseases with similar symptoms, like Lewy body disease or Huntington's disease. Okay. Facts about Alzheimer's disease. It is the most common cause of dementia in the elderly. More than 6 million people in the US are living with Alzheimer's disease. As of 2025 census, according to the US Bureau of Census, there's actually closer to 6.9 million people in the US who have Alzheimer's disease. Okay. Or a related dementia. Women are more likely than men to have AD. That being said, women also have a tendency to live longer, and that's why they're also more likely to actually be diagnosed with Alzheimer's versus men. Risk increases with age, but it is not a normal part of aging. AD is progressive, degenerative, and irreversible. So once that person is diagnosed with Alzheimer's, there isn't really much that they can do to help prevent the progress of the disease. Okay. Tangled nerve fibers and protein deposits in the brain cause dementia. The cause is currently unknown and diagnosis is difficult. Length of time from onset to death can range from 4 to 20 years. So from the time that they first get diagnosed with Alzheimer's to the time that they actually die from complications related to the Alzheimer's disease can be in as little as 4 years or as long as 20 years. Okay. In the long-term care facility where I used to work at, one of our residents actually, from the time she was first diagnosed until the time that she eventually passed away, it was almost 18 years. So yeah, that's actually pretty good. Um, each person will show different symptoms at different times. So not everyone who has Alzheimer's disease is the same in the signs and symptoms that that shows up. And so don't assume that, oh, because this person has confusion and this person has confusion, that they all have Alzheimer's disease. It might be a different diagnosis. Okay. All right. And then some points when caring for residents with AD. Every person with Alzheimer's progresses differently, showing different symptoms at different times. So based on the symptoms that they're showing, that's how we would treat them or plan their care. Okay. And residents should be encouraged to do self-care and keep their minds and bodies active for as long as possible. Because the longer that they stay healthy and physically and mentally active, the slower the progression of the disease and the longer they're going to live. Okay. With a higher quality of life. Versus if all they do is sit down all day long just watching TV, their Alzheimer's disease is going to get progressively worse or faster than someone who is mentally and physically active. Okay. All right, so some helpful attitudes for working with residents with AD. Do not take things personally. With certain residents who have AD, sometimes they can be physically and verbally abusive towards us as their caregivers, and yeah, you shouldn't take it personally. Um, even when they're being physically or verbally abusive towards us, they can't help it. It's actually caused by the disease. That's what's causing them to act that way, not necessarily anything that you did. Okay. So yeah, you need to remain professional when you're dealing with those particular residents or clients. All right. Be empathetic and try to remember again that it's the AD that's causing them to act that way, and it's not anything in particular that you did. Work with symptoms and behaviors noted, work as a team. So if you need to take a break because you're just too stressed out from dealing with that particular patient, they're just really getting on your nerves, then yeah, take a quick 5 minute break. Go to the bathroom and lock yourself in. Even if all you do is just stand there in the bathroom, okay, or do something to actually take your mind off of what happened. So that way you don't end up doing something that you'll regret later, like abuse the resident. Okay. So yeah, let your coworker know if you just need to take a quick break, like a 5 minute break. Right. And that way, when it's their turn and they need to get away from their resident or patient, then you will also relieve them and watch over their patients while they take a breather. Okay. Be aware of the difficulties associated with caregiving. It can be very trying, dealing with patients who have or clients who have dementia. Okay. And so, yeah, it can get draining after a while and tiring. And especially for those of you who are going to be living with clients in your family's care home or adult foster care, you can't really get away from them. Okay. You can't get away from your clients except maybe to go to your room. But otherwise, they're always there. You always have to take care of them 24/7, 365. So you need to, when it's your turn to have your day off or it's time for you to take your break, maybe your mom told you that, oh, go ahead, uh, uh, go shopping if you want to with your friends. And then when you come back, then you can relieve me while I cook dinner. And yeah, take that break. Okay. That way you don't get overstressed from taking care of the clients. All right. So yeah, work with family members also, especially if you're working in a healthcare facility, you can ask the family members of the patient or resident if they can help us out in taking care of that particular patient or resident. An example of that is if you notice that the patient or resident eats better when their family is there during meal times, then ask if the family can visit during meal times. Okay. Um, whether it's lunchtime or dinner time, it doesn't really matter. As long as they come and visit during at least one meal time, so that way the patient or resident has at least one good meal in every day. Okay, so sometimes we'll have those residents that they eat better, they're more comfortable when the family member is there because they're used to their presence. They feel more secure in themselves, and so they are more likely to actually eat their food. So ask the family, oh, is it possible for you to come during meal times so that way she'll eat all of her food? We can only ask, and it's up to them if they actually can accommodate our requests. Okay. And also remember to check the goals of the care plan. What is stated in the care plan regarding what we're supposed to do when taking care of that particular resident or patient? Okay. If there's anything special, any special instructions that we should be following. All right, and then we have the following key term, perseveration. We're on page 118 of your book. It is the repetition of words, phrases, questions, or actions. And when communicating with a resident with AD, always approach them from the front, never approach them from behind or from the side. Because with a person who has Alzheimer's disease, they get startled easily. If you try and approach them suddenly from the side or from behind and you start talking to them, they could get startled and overreact and try and punch you or hit you. Okay. So always approach from the front, get their attention before you actually start talking to them. Okay. Same thing as you would with someone who is angry or combative. You wouldn't want to approach them from the side or from behind. As much as possible, get in front of them before you start talking to them. Okay. Smile and look happy to see the resident. Be friendly. Good morning, Mrs. Smith. How are you today? Kind of thing. Okay. And determine how close the resident wants you to be. So with certain residents, they don't mind if we're at a normal distance from them when we're talking to them. So if they're sitting down and we approach them, then typically we're going to be at least one half of an arm's length from the half of an arm's length or about 2 feet away from them, 2 to 4 feet away from them while we're talking to them. If they're standing, then yeah, you should be at least 3 to 4 feet away from them. Any closer and they might feel uncomfortable. Okay. They might be confused. Why is this person in my space? Okay. So make sure that you find out how comfortable that person is with how close you get to them while communicating. Communicate in this calm area with little background noise and distraction. Always identify yourself and use the resident's name and continue to use the resident's name every other sentence. And speak slowly using a lower tone of voice. So don't speak too fast when you're talking to someone who has dementia, because then that might just actually increase the confusion that they're experiencing. Yeah, don't give too much information basically when you're talking to a person who has dementia. That'll only increase their confusion. And they'll be like, why are you here? Repeat yourself using the same words and phrases as often as needed, so at least twice, and then make it more simple the third time around. Use signs, pictures, gestures, or written words to help communicate. If you repeated yourself word for word at least twice, and then you phrase it again in a more simple way the third time around, they still are just staring at you or they don't know what to say, then write it down. Usually, especially if the person is still in the early stages of dementia, it'll make it easier for them to actually understand you. Okay. And then break complex tasks into smaller, simpler ones in order to get the person to actually follow or give in to your instructions. If you like give them more really complex tasks, like, come on, Mrs. Smith, get out of bed. I'm ready for breakfast. They'll be like, okay. They'll just stare at you versus telling them, okay, Mrs. Smith, I'm going to help you to get up out of bed. All right. I'm going to help you sit up first on three. 1, 2, 3. All right. Yeah, put on your slippers. Okay. I'm going to help you stand up from the bed on three. 1, 2, 3, etc. Okay. So break it down into simpler tasks versus general instructions. And if the resident is frightened or anxious, speak in a low, calm voice and speak in a quiet area with few distractions. You don't want any loud noises or sudden noises to startle the resident and scare them even more. Okay. Also, try to see and hear yourself as residents might and describe what you're going to do. Always be aware of your body language. Also, be aware of the fact that if your resident is sitting down, like if they're in a wheelchair or chair and you're talking to them while standing over them, um, they might get scared of you. So instead of talking over them while they're sitting in the chair or wheelchair, it's best if either sit down also in a chair across from them, or if there's no chair available, then you're going to crouch down next to the chair or wheelchair so that you're hopefully within eye level of the resident. So that way they're more likely to listen to, or pay attention to what you're saying and not feel anxious. Okay? Let's see. Use simple words in short sentences. Check your body language and make sure that you're not tense or hurried. Make sure that you pay attention to your body language. Don't cross your arms while talking to them. Don't put your hands on your hips while you're talking to them. Obviously, don't be tapping your foot or your hands on the furniture. That's just going to further intimidate or scare the resident, especially if they're confused to begin with. Okay. If the resident forgets or shows memory loss, repeat yourself using the same words. If a resident does not understand a word, try a different one. If a resident perseverates, excuse me, answer questions using the same words each time. So when you're talking to the resident and if they perseverate or basically repeat back what you just said, then you're just gonna answer the questions using the same words every time. So I actually had a resident that was like that at the first long-term care facility that I worked at in my career. So anytime that you would talk to him, the resident would just repeat word for word what you said to them. And then the only way that we knew what he was trying to communicate to us was based on his body language, including his facial expression. So if you said, "Good morning, Mr. Smith, how are you doing today?" he would repeat it word for word. "Good morning, Mr. Smith, how are you doing today?" And so when he would perseverate or repeat back what we said to him, we would just look at his face. Does he look happy? Does he look sad? Does he look comfortable? If he's happy or comfortable looking, then okay, no problem then. If he's like frowning or looks unhappy, or if he's upset, then we know that either um, there's something going on with him. Either he's hungry, or he had an incontinent episode, or he might be in pain and he wants to be turned or get his pain medication. So usually that will work most of the time with that particular person. So you want to familiarize yourself with your residents who have a tendency to perseverate. Okay. Also be careful of what you say to them because again, they're going to repeat word for word what you said to them. That particular resident, he did not get along with any of his roommates. They got tired of listening to him repeat back everything that he heard. And so they would curse at him and he would just curse back right at them, word for word. So that would just make his two roommates even more angry. Okay. So yeah, we learned to actually put him in another room with other residents who are quiet and basically nonverbal. And so yeah, they didn't mind him talking because he wouldn't talk otherwise unless he heard someone else saying something. Okay. Keep messages simple and break complex tasks into smaller, simpler ones. If a resident has trouble finding words or names, suggest a word that sounds correct and try not to correct a resident who uses an incorrect word. So you might have a client or resident that's like, oh, blah, 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 blah. And then so you have to basically play the guessing game with them. Bathroom, Mrs. Smith, do you need to use the toilet? Do you need to go and pee or poop? Okay, if they say no. Okay, bed, do you want to go back to bed? Are you tired? Are you tired of sitting up in your wheelchair or do you want to take a nap? Okay. So yeah, try and figure out what they're trying to communicate to you. So if she's like, still no, okay. So that's when you're trying to guess exactly what they're trying to tell you. If after a couple of tries, you still haven't figured out exactly what they're trying to say to you, then just distract them or get them to focus on something else instead or some other activity instead. So that way you both don't end up getting frustrated trying to communicate with each other. Or if that person is still able to write down messages, then ask them to write it down. Mrs. Smith, can you write it down for me? I really can't figure out what you want. And yeah, if they're able to write down, awesome. If not, then okay, distract them. If the resident seems not to understand basic instructions or questions, ask the resident to repeat your words back and use short words and sentences and allow time to answer. By having them repeat back what you just said, it helps to confirm whether they actually heard or understood what you're trying to communicate to them. If they like just stare at you when ask them to repeat back what you said, then you know that either they didn't hear you, they didn't understand you, or they don't just care. Okay? They're not really paying attention to what you just said. All right. Use the communication methods that are effective. So make sure that you check the care plan, watch for nonverbal cues, and observe body language to see whether they're happy or sad, uncomfortable or in pain, etc. So hopefully we can find out if they're actually if they really are able to communicate to us or not, verbally, or if they understood what we're trying to tell them or not. And use signs, pictures, gestures, or written words to reinforce the message. So, especially when you're dealing with a resident who is confused, like they have dementia, and they're also hard of hearing. Oftentimes, what the staff will do in long-term care and assisted living facilities is we'll just write it down. And hopefully, the resident, when they read that message, it'll get the message across to them. Okay. If the resident wants to say something but cannot, then encourage the resident to point, gesture, or act it out. So again, we're going to play the guessing game and trying to figure out exactly what they're trying to communicate to us, especially if they're only able to point. Okay. Offer comfort with a smile if a resident is upset or try to distract them. So again, if they're trying to tell us something, but we can't figure it out, and they can't really write down the message because they've even lost the ability to write, then yeah, we'll try and either comfort them with a smile or distract them with a different activity. And hopefully they forget what it was that they were trying to communicate to us. Okay. But we always try and start with the basics. Do they need to use the bathroom or did they wet themselves? Are they tired and do they want to go back to bed? Or are they hungry or thirsty? Those are the four basic questions that we usually ask. Okay. All right. If a resident does not remember how to perform basic tasks, then break each activity into simple steps. If a resident insists on doing something that is unsafe or not allowed, then limit the times you say don't and redirect activities instead. With residents who are confused, if you tell them no, they can't do something or don't do something, that usually they will actually just become more stubborn and insist on doing that activity instead. So what we'll typically do is we'll distract them. We're going to redirect them to a different area where it's safe for them to wander around, or we'll distract them with some activity that they enjoy doing. So that's why in a lot of long-term care and assisted living facilities, we always have a lot of magazines, newspapers, also pack of playing cards or other stuff that the person can do by themselves to help distract the residents, especially when they're trying to do something or go into areas where they're not supposed to. Okay. If the resident hallucinates or is paranoid or accusing, try not to take it personally and try to redirect the behavior or ignore it. So, depending on the hallucination or accusation, we would just ignore it, okay, or we would redirect their behavior. So, an example of that is if the resident tells us that they see ghosts. Okay, that's a common hallucination. If the person says that they see ghosts floating around in the room, you just like, okay, I believe you see ghosts, and then move on to another topic or do whatever it is that you're supposed to be doing there at the bedside. Okay, move on. You're gonna ignore it. But if the person starts saying anything where they want to harm other people, like if you're taking care of, say, a military veteran or a first responder, like a paramedic or policeman, firefighter, and they tell you that they're going to go and rescue the hostage or they're going to go and break down the door, like with a firefighter, then no, that's the time that you need to make sure that they don't actually carry out that threat of breaking down the door or rescuing the hostage, because then they might end up hurting other people or hurting themselves. Okay. So that's the time that we want to take away any objects that they could use to potentially hurt other people, like scissors, any knives, nail cutters, razors, etc. So that way they can't potentially use it. Okay. Otherwise, yeah, just keep an eye on them just to make sure that they don't do anything they're not supposed to. If the resident is depressed or lonely, take time one-on-one to ask how they're feeling and listen to the response. Sometimes the residents, if you're working in long-term care assisted living or in a family's care home, they just want someone to talk to. So just taking even just 5 minutes out of your day to listen to them while they talk story or just do talk about whatever it is that they want to talk about. Sometimes that's enough to make them happy. Okay. And so, yeah, try and make that time if you can, especially with those residents who get lonely easily. Try to involve the resident in activities and report any signs of depression to the nurse. Or if they tell you that they miss their family and their family or other visitors haven't come to see them in a long time, then tell the nurse so that way the nurse can contact the family and see if they can come and visit the resident much sooner. Okay. Or remind them that, hey, you haven't come to visit the resident and Mrs. Smith is feeling lonely. So hopefully the family will come in and see them. All right. If the resident repeatedly asked to go home, ask the resident to tell you what their home was like and how he felt being there. So again, you're going to distract them. Redirect them to something that they enjoy and expect questions to continue and remain patient and gentle with responses. So actually, in all of the facilities that I've worked at, whenever we have a patient or resident, especially those who are confused, who tell us that they want to go home, what we'll do is we'll actually walk with them up and down the hallways and talk to them at the same time to distract them about wanting to go home. And hopefully, just the mere act of walking up and down the hallways will tire them out and they completely forget about wanting to go home. Or if they are asking to go home, what we'll do is, if walking them around doesn't help, bring them back to their room and then either offer to take them to the toilet or offer to help them get back in bed and take a nap. Because for a lot of the elderly, especially this current generation, when they think of home, they're usually thinking about their bedroom. Okay, getting in bed because they're tired, or maybe they just want to take a quick nap, or it might be that they need to go and use the toilet, but instead they're thinking of home instead. Okay. So by offering those two things, helping them to get back into bed or helping them to the toilet, usually that will help to relieve those feelings of , missing home. Okay. Right. If the resident is verbally abusive or uses bad language, remember it is the dementia speaking, not the person. Try to ignore the language and redirect their attention to something else. So remain professional. Don't be swearing back at them, okay? Yeah, I've only had a couple of incidents in my entire career of a resident or patient being verbally abusive towards me, but I never take it personally because I know that it's usually because they're either frustrated or like with that one patient resident of mine, she thought that I was her bad neighbor. And so that's why she would always yell at me or curse at me because she thought that I was her enemy, basically. So I never took it personally. All right. But yeah, you need to remain professional. Right. If a resident has lost most verbal skills, then also use nonverbal skills in communicating with them. You're still going to talk to them, but you're going to reinforce the message through either touch, smiles, and laughter, or also using physical gestures. So, like when you're telling them that it's time to eat. So, time to eat. Mrs. Smith, time to eat. So, that's the American Sign Language for eating. Okay. You're going to curl up your hands together like this and bring it up to the mouth. That's eating. Okay. Use signs, labels, and gestures and assume that people can understand more than they can express. So just because that person is nonverbal doesn't mean that they can't understand you anymore. They can still hear and understand you just fine. The problem is they have difficulty in verbalizing what they want to say. Okay, because of their dementia. But yeah, they'll still understand you. So don't assume that they can't understand you and badmouth them or anything like that. NAs working with residents with AD should remember these three general principles for providing care. Develop a routine and stick to it. So that's why whenever we get a new admission into long-term care, assisted living, or for those of you who are going to be working in your family's care home, try to find out the typical routine, daily routine of your clients or residents. So find out when they usually get up out of bed in the morning, when do they typically eat, what time do they typically like to take a shower or a bath? What do they usually like to do after breakfast or after lunch, etc.? What time do they usually like to go to bed? So those are all things that we want to find out so that we can um, schedule a routine and make them feel more comfortable staying in the facility or staying in your care home. Okay. Promote self-care or encourage them to do what they can for themselves. And also remember to take good care of yourself, not just of your client or resident, both mentally and physically. You can only give excellent care to other people by taking excellent care of yourself. Otherwise, if you're like doing all of this excellent care on your residents, but then you forget to take care of yourself, you forget to eat or drink or go and use the bathroom, you're going to more likely get sick. Okay. And yeah, you're not going to be able to work or take care of those people that you're supposed to. All right. Okay. Interventions for ADLs. For problems with bathing, schedule bathing when the resident is least agitated or when they prefer to take a bath or shower. Give the resident supplies before bathing to serve as a visual aid, or make sure that you bring it into the bathroom. And so when you bring them into the bathroom and they see that the supplies are already there, then yeah, it helps to reinforce the message to them. Take a walk with the resident down the hall and stop at the tub or shower room. So that usually works with those residents who don't like to take a shower. Rather than telling them that, okay, I'm going to take you for a shower, Mrs. Smith. No, we're not going to do that. Instead, what we're going to do is we're going to take that resident or client and take them for a walk, even if they're in a wheelchair. Take them for a walk in the hallway, and then once they're like distracted by that walking in the hallway, then we're going to Bring them into their bathroom. Mrs. Smith, look, there's the bathroom. You want to use the toilet? Have them use the toilet. And then after they use the toilet, then you're going to ask them, or tell them, Mrs. Smith, since you're here in the bathroom already, I have everything ready for your shower. You want to take a shower? I have your towel and washcloths all there. Your bathrobe is right there also. About 8 times out of 10, they're going to say, okay, yeah, and agree to take a shower. Okay. So yeah, that's a way for distracting the resident or client from what we want them to do. So since they're already there in the bathroom, yeah, most of them just give in and allow us to give them a shower. All right. Make sure that the bathroom is well lit and at a comfortable temperature. Make sure that there isn't any breeze or draft that's coming into the bathroom because that's the most common complaint that a lot of patients or residents complain about. That, oh, it feels cold in there. So make sure to close any windows or close the bathroom door while the person is taking a shower or close the shower curtain so that way they don't feel any breeze coming into the bathroom. Okay. Provide privacy. So again, close the bathroom door and or the shower curtain so that way other people who are passing by can't see them. Uh, be calm and quiet and keep the process simple. So when you're helping to bathe someone or give them a shower, just explain to them every single step of what you're going to do. But yeah, otherwise, most people don't like it when you're like talking too much while they're taking a shower, or a bath. But then there are those residents, especially this current generation of the elderly, who actually enjoy it when you sing to them while they're taking a bath or shower. So if you ever have a client or resident that's like that, then yeah, learn to sing some simple songs that most locals are familiar with, like Pearly Shells, or some Twinkle Twinkle Little Star. You might be like, isn't that a kid's rhyme? Well, with a lot of locals, they still enjoy that kind of song. And so, yeah, we have those residents who enjoy those kinds of simple things while they're taking a shower or bath, right? Be sensitive when discussing bathing. Make sure that you refer to body parts by their proper names. Don't use slang words, or uh, don't use slang words or other language for referring to body parts. So, like if you're going to ask your resident to clean underneath their breast, then tell them, Mrs. Smith, here's a washcloth. I already wet it down and added some soap. Can you wash underneath your breast for me? Okay. Simple as that. Or if you're taking care of a male resident or patient and you need them to clean their private area, then tell them so. Mr. Smith, here's a washcloth. Can you clean your penis for me? All right. So that way there's no miscommunication at all. And hopefully they'll actually do what you're asking them to do instead of just like relying on you, especially if they're still physically capable of doing it on their own. Okay. Give the resident a washcloth to hold during the bath. So while you're giving them a shower or a bath, you can give them a washcloth, and hopefully that will encourage them to participate. So you can tell them, Mrs. Smith, go ahead and wash your face with that washcloth. Or while you're shampooing their hair, Mrs. Smith, go ahead and cover your eyes with the washcloth so that the shampoo doesn't get in your eyes. Okay. Or Mrs. Smith, go ahead and scrub what you can reach while I wash your back and your legs. Okay? That increases their sense of independence. Ensure safety by using non-slip mats, tub seats, and handholds. Make sure that you check that the grab bars in the bathroom are securely fastened to the wall. If you notice that they're loose or they jiggle whenever you check on it, then make sure to inform the nurse and also make a maintenance request before you actually use the bathroom. For those of you who are going to be working in your family's care home, obviously you're going to let the care home operator know, and also whoever is going to be responsible for fixing those, that doing any maintenance, um, like repairs within the house. Okay. Um, it might be you if you're handy, or it might be the care home operator or some other family member. Make sure that they know that that needs to be fixed. Okay. Be flexible about when to bathe and understand if a resident doesn't want to bathe, especially when there's cold weather. A lot of residents, they don't want to take a bath or shower first thing in the morning. Instead, ask them what time they would prefer. It might be that they'll tell you, oh, maybe before lunch, or they might tell you that, oh, maybe after lunch or before dinner. Okay, then you need to accommodate them. Okay, that's their choice. And be relaxed and offer encouragement and praise. Okay. Let the resident do as much as possible for themselves. Check the skin for signs of irritation, because oftentimes when a person has dementia, they forget to tell you things because obviously they're confused. And so they might not remember to tell us that, oh, they got a bruise when they banged into their bedside table, or maybe they bumped into the doorway when they were going to the bathroom, and now they have a bruise on their elbow or a tear on their arm. Okay, depends on what happened to them. So always check the skin for any signs of irritation or breakdown while you're helping them to take a bath or helping them to change their clothes. Okay. For problems with grooming and dressing, help with grooming and avoid delays or interruptions. Provide privacy as needed, especially when they're getting dressed. Show the resident the clothing to be put on. So ask them, if they have dementia, instead of asking them, Mrs. Smith, would you like to wear this t-shirt or this blouse? Would you like to wear a skirt or pants or shorts? No, you're going to show them two complete outfits of clothes that they typically like to wear. Okay, or two outfits that they typically like to wear. And then ask them, Mrs. Smith, would you like to wear this outfit or this outfit? And then if they tell you that, oh, I like that outfit, I like the purple one, but can you, instead of that sweater, I want a different sweater. Okay, they just made choices and you made it easy for them to decide. Okay, so try and limit it to two. So it's easier for them to actually decide what they want to wear. And then, yeah, encourage a resident to pick out clothes to wear and then lay out the clothes in the order to be put on. It makes it easier for you if you're going to help them get dressed. And it also makes it easier for the resident when they are able to dress themselves. So their underwear should be on the top of the pile of clothes, with their outerwear, like a sweater or a vest, on the bottom of the pile of clothes. Shouldn't be on top. Okay. I've actually had some residents that the nurse aides forget that, and then they're kind of embarrassed to see underwear, and so they put it on the bottom. Well, I have had some residents that they'll put on the outerwear, like the jacket, on first, and then the t-shirt over it, and then they'll put their pants on and then their underwear. We don't want that because it just makes more work for us. Okay. So always arrange the clothes in the order that they're going to put it on. Actually, that's also going to be one of your test questions. Break the task down into simple steps and do not rush the resident. And then use a friendly, calm voice when speaking and praise and encourage, especially if they're able to do things on their own. Okay. And then for problems with toileting, encourage fluids. So every time you see them, as long as they're not on fluid restrictions, offer them something to drink. So you, again, offer them two choices of beverages. Hi, Mrs. Smith. I'm just checking in on you. Are you okay? Do you need to use the toilet? No, you're fine right now. All right. Do you want to drink some water or some apple juice? If you want apple juice, I can go and grab it from the refrigerator. And if they tell you no, they'll just drink water. Awesome. Okay, but encourage fluids. Mark the bathroom with a sign or picture, especially for those residents whose dementia is getting progressively worse. Oftentimes, just seeing the bathroom is not enough. Having that extra door in their room, they'll forget that that's a toilet. okay, or bathroom. And so we might have to put a sign on the bathroom door, saying bathroom, or we might even put a picture of a toilet bowl on the door to remind the resident that, yeah, that's a bathroom, or they can go and pee or poop. Okay. Make sure that there's enough light in the bathroom and on the way there. So if you're working in a healthcare facility, typically in most hospitals and long-term care facilities, we have automatic lighting, so you don't have to worry about it. It comes on immediately once it senses or detects movement. But if you're working in your family's care home or in the less equipped long-term care facilities, yeah, you might have to turn on the light first to the bathroom. So if you are working in a facility where you have to turn on the light, make sure that you turn on the bathroom light before you go and help the resident to get up out of bed. Okay? So that way you won't be like, oh, holding on to your resident or patient and at the same time trying to find the light switch. No, turn on the light first in the bathroom before you go and help them get out of bed. All right? Note when the resident is incontinent, check them every 30 minutes and take the resident to the bathroom before bathroom time. Observe toilet patterns for 2 to 3 nights if the resident is incontinent during the night. So for that one, if the resident is, if we're told that the resident or patient is continent, but they're having incontinent episodes, that means that we're not taking them on time or on a timely basis to the toilet. Okay. So when they're first admitted into the facility or into the care home, we want to try and find out when they typically become incontinent. So if they're incontinent only at night, and you're only going in to check on them at 2 o'clock, then that means that, yeah, 2 a.m. is too late for them to go to the toilet. And that's why they end up wetting themselves. So instead, you might need to go to help them to the bathroom earlier in the night, maybe 1 o'clock instead. So when you help them to the toilet before they have an incontinent episode, it helps to prevent accidents from happening. Okay. Take the resident to the bathroom after drinking fluids and make sure that the resident urinates before getting off the toilet. So again, with a person who has dementia, oftentimes they'll just forget what they're supposed to be doing while sitting on the toilet, especially when they're in the advanced stages. So you need to remind them what they're supposed to be doing while sitting on the toilet. Mrs. Smith, okay, I'm gonna help you sit down on the toilet. And then after you help them sit down on the toilet, okay, then you remind them, Mrs. Smith, go ahead and pee or poop, okay? I'll be right outside the door. So you have some privacy. And then after 5 minutes, ask them, Mrs. Smith, are you okay in there? Have you finished peeing or pooping? And if they don't answer, then yeah, go into the bathroom, check on them. What are they doing? I've actually had some residents fall asleep on me while sitting on the toilet. So that's why we don't wait longer than 5 minutes to remind them what they're supposed to be doing. Okay. And yeah, we want to make sure that they actually pee before we stand them up from the toilet. You don't ask them, did you pee while you're helping them to stand up and pulling up their clothes? Because then if you say, oh, did you pee? Most often the response would be that they'll just suddenly start peeing. So yeah, you want to ask them if they peed while they're still sitting on the toilet. Okay. Please don't be like one of my nurse aides where she asked the resident that if she had finished peeing and when she already stood her up and she was pulling up her underwear. And so the resident actually ended up peeing all over her underwear, the nurse aide's hands, thankfully she was wearing gloves, and also the nurse aide's shoes. So you don't want that happening to you. Okay. So always ask them while they're still sitting on the toilet if they finish peeing. Okay. Or if they peed. Take the resident to the bathroom before and after meals and before bed to give them an opportunity to actually pee or poop as needed. Put lids on trash cans, waste baskets, or other containers if the resident urinates or defecates in them. Sometimes when the person is confused, they'll just grab any open container and pee or poop in it. Okay. I once had a resident that liked to just grab his water pitcher and then pee in it. And so, for that particular resident, we wrote it in the care plan that he's always going to have at least two urinals available. So that way, if he pees in one, he'll have another spare urinal to use in case he gets the urge to pee. Okay. So yeah. This is something that we would keep at the bedside for male residents, especially if they pee a lot. Rather than having to help them to the toilet every single time, we'll just give them a urinal instead. Okay. And be professional when cleaning after episodes of incontinence. Be professional and don't like make any remarks while cleaning them up. Don't be like, oh, Mrs. Smith, your poop is so stinky. Or, oh, Mrs. Smith, can't believe you peed that much. That's actually a form of psychological abuse towards your resident or client. So please do not make those kinds of remarks. Okay? Right. For problems with nutrition, encourage nutritious food, have meals at consistent times each day. Food should look and smell appetizing. So yeah, you want to make sure that, especially for those of you who are going to be working in your family's care homes, make sure that you always serve your clients their meals at set times. So if they're used to getting breakfast at 7:30, make sure you always serve them their breakfast at 7:30. If they're used to having their lunch at 12 o'clock, then make sure you serve it at 12 o'clock. It shouldn't be, oh, you're going to give it at 11 or at 1 o'clock. No, if they're used to getting at 12 o'clock, feed them at 12 o'clock. All right. So that way they get used to it and they feel they're less likely to complain about feeling hungry or complain that, yeah, you're abusing them. Okay. Make sure that there's proper lighting, keep noise and distractions low, keep the task of eating simple. Finger foods are easier to eat. Sometimes we'll have those residents who are in advanced stages of dementia where they're kind of like little kids that they don't want to sit down during meal times. Instead, they'll be walking around. They're hungry, but they're just walking around the table or standing off to one side. So instead of forcing them to sit down to eat their food, instead we'll just give them finger foods like sandwiches, cut up fruit or vegetables that they can easily just hold and eat while they're standing. Okay. And then when they finish their sandwich, then you just hand them their cup or other container that has their beverage and then encourage them to drink before you give them some more food to eat. Okay. Do not serve steaming or very hot drinks or hot foods or drinks to people who have dementia because believe me, they will not check the temperature. They're just gonna start eating. And even if it's like really hot, like hot coffee or hot tea, they're still gonna drink it. And then even if they have burns, yeah, they won't care because they're confused. Okay. So we need to make sure that the food or drinks that we're serving to them aren't too hot for them to comfortably eat or drink. Otherwise, they could easily get scalded. Use plain plates without a pattern or color. Use a simple place setting with a single utensil and remove other items from the table. Oftentimes if you use really fancy patterns, for the tableware, that can easily confuse the resident, or distract them. And so, yeah, in most healthcare, facilities, uh, you'll notice that the utensils are plain. They don't have any designs on them. It's actually got two purposes. One is to make it easier for the dietary department to actually clean the utensils and plates, and also to see if there's any food that's still stuck on there. Okay. So, and then second reason is if you're dealing with people who are confused or delirious, they won't be distracted by the patterns that are on the plates or on the utensils. Okay. Oops. All right. There's my plate. Hey, what happened? I'm not done yet. Okay, I'm almost done. Here we are. Put only one item of food on the plate at a time. So on that one, again, if you have a resident that's easily distracted by or gets more confused, if you put too many food items in front of them, keep it simple. Just put their plate of food right in front of them that has their main dish together with their starch and vegetable. And then once they finish that, then you give them their dessert or their salad. Okay. Don't be putting their plate together with their salad and their dessert in front of them because then they don't know what they're actually going to eat first or drink first. So that's what we mean by just putting one item in front of them at a time. Okay. Give simple, clear instructions for eating or using utensils, like place the spoon to the lips and then ask the resident to open their mouth. Okay. So yeah, you want to keep it simple. Give one instruction at a time while you're helping that person to eat. Guide the resident through the meal with simple instructions and offer regular drinks to avoid dehydration. So every 2 to 3 bites of food, offer them something to drink or encourage them to drink to drink something. Use adaptive equipment as needed. So it's going to be on their dietary card if you're working in a healthcare facility. If they're going to be using any kind of adaptive equipment, including if they're supposed to use an adaptive spoon or other utensils, or if they have any other special equipment that they're supposed to have. So always double check that it's on the meal tray and that the person knows how to use it. If not, then let the nurse know. Okay. Whether if the equipment is missing or if the resident doesn't know how to use it correctly. Feed the resident slowly, giving small pieces of food. Make mealtime simple and relaxed. Give the resident time to swallow each bite before giving them another bite of food or before giving them something to drink. That way they don't choke. Seat the residents with others to encourage socializing. Yeah, let them sit together with their friends. Don't sit them next to someone that they don't get along with. Otherwise, you're going to have patients or residents that are going to be fighting with each other. Okay. And observe for any eating and swallowing problems and observe and report any changes or problems and monitor their weight frequently or per the care plan. At the very least, they should be weighed monthly. Okay. And then to promote physical health, prevent infections and follow standard precautions, observe the resident's physical health and report any potential problems, help the resident wash their hands frequently, give careful skincare to prevent pressure injuries, watch for signs of pain, report possible signs of pain to the nurse so that way we can give them pain medication as needed, and maintain a daily exercise routine. To promote mental and emotional health, maintain self-esteem by encouraging independence, not dependence, independence, allowing them to make choices, share in enjoyable activities, looking at pictures, talking and reminiscing, and reward positive and independent behavior with smiles and warm touches. Good job, Mrs. Smith, kind of thing. Okay. So, all right. Okay. So I'm going to let you go early if you want to. It's already 1 o'clock. If you want to stay until 1:30 when the class actually ends, then feel free to do so. Otherwise, yeah, if you want to leave the class already, I won't hold it against you. Okay. I'm still going to send all of you the recording or the link to the YouTube video once I've finished uploading it. But yeah, otherwise, if you want to leave, like if you have to attend a party, then feel free to do so. Okay. Thanks. Someone had a question. Okay, yeah, see you next weekend, Ruben. Okay, so we have the following key terms. Sundowning is becoming restless and agitated in the late afternoon, evening, or night. Catastrophic reaction is reacting to something in an unreasonable or exaggerated way. Pacing is walking back and forth in the same area. Wandering is walking aimlessly around the facility or facility grounds. They don't know where they're going. Okay. Elope is in healthcare when a person, not just a person with Alzheimer's disease, but any person, especially those who are confused, wanders away from a protected area and does not return. So, yeah, we need to worry about when we're taking care of any confused or delirious patients or residents if they have eloped or wandered away from the facility or from the safe area. Okay. Hallucinations are false or distorted sensory perceptions. Delusions are persistent false beliefs. Rummaging is going through drawers, closets, or personal items that belong to oneself or others. And hoarding is collecting and putting things away in a guarded way. So yeah, when they're hoarding, they just collect items and store them, even though they don't really have a use for those items. Okay. So with difficult behaviors in management, we're on page 123 of your book. We have agitation. So when the resident is agitated or anxious, we want to remove the triggers. What's causing them to act that way? If they're hungry, then give them something to eat. If they're thirsty, then give them something to drink. If they're agitated because they either had an incontinent episode or they need to go and use a toilet, then do so. Clean them up or take them to the bathroom. Okay. So remove the trigger of what caused them to be agitated. Keep to the routine, reduce noise, focus on a familiar activity, remain calm, and soothe them as needed or comfort them as needed. For sundowning, you want to avoid any stressful situations, especially in the afternoon or evening times. So that way the person doesn't feel even more agitated. Okay. You want to limit activities and appointments during those times also. And then you might play soft music around bedtime to actually help to get them to go to sleep. You want to set a bedtime routine where if we want them to go to bed by 8 o'clock, then yeah, help them to get ready to go to bed before 8 o'clock. So help them to the bathroom, help them to wash their face, brush their teeth, change into pajamas, give them a bedtime snack if they're allowed to have a bedtime snack before they go to sleep. Okay. Plan a calming activity before bedtime. So that way they feel relaxed enough that, oh, yeah, they're going to go to sleep. So an example of that is if they like to read before they sleep, then give them something to read. If they like to watch a certain TV program before they go to sleep, then turn on the TV to that TV program. Okay. The most important thing that we also do if the person is prone to sundowning is we would limit their caffeine intake or completely eliminate it from their diet. So we would not serve that person any caffeinated beverages like coffee or tea, or anything that has chocolate in it after 11 a.m. In some long-term care facilities, um, even when they have coffee that's being served, it's actually decaf. But we don't tell the residents that it's decaf coffee. Okay. Because with an older person, they retain certain nutrients longer in the body because their digestion is slow, just like I talked about in the last chapter. And so with caffeine, it remains in their body much longer than with younger adults. And that's why we would either not give them any caffeine after 11 a.m. or we would completely eliminate it from their diet. Okay. Provide snacks, give a back massage, distract, and maintain a daily exercise program. By having them exercise daily and hopefully get tiring them out, by the time bedtime comes around, they're too tired to stay up and walk all night or talk or do other stuff all night long. Okay. Catastrophic reactions. Avoid triggers such as fatigue, changes in staff, or changes in their routine. Overstimulation, like really loud noises or too much activities or people around them. Difficult choices or tasks. Pain, hunger, or need to use a toilet. Remove those triggers and distract them as needed. Okay, so Like, say, if the resident is having a catastrophic reaction, and then they're also an example of that is they start screaming and yelling because they don't know you. You're a brand new nurse aide helping to take care of them, and they don't want you anywhere near them, then yeah, you need to get out of the room. Give them that time to actually relax. Or what you can also do, especially if that person is at risk for falls or other injuries, is that you might distract them with something that is very comforting to them, like giving them activity that they can do, or giving them a comfort animal or toy, like a stuffed toy that they love. Here, Mrs. Smith, here's your favorite doll. And then once they are holding that doll, usually it after a few minutes they'll calm down. Okay, so give them something that they can be distracted by. With violent behavior, we talked about this back in chapter 2. Call for help, block blows, never hit back, step out of reach, and do not leave the resident alone. Just in case they try and go after other residents or other staff members. Remove any triggers and use the same calming techniques as for agitation and sundowning. And then for pacing and wandering, it can be caused by restlessness, hunger, disorientation, incontinence, or need to use the toilet if they don't know how to ask or look for, know where the toilet is located, constipation, pain, forgetting how or where to sit down, too much napping, especially during the daytime, and need for exercise. Excuse me. So when that happens, you want to remove the causes of their pacing or wandering. So if they need to use the toilet, then make sure that you routinely offer to take them to the bathroom. Okay. So bring them to the bathroom, remind them that, oh, here's the bathroom, Mr. Smith. Do you need to go and pee or poop? So that way they have that opportunity. Okay. Give snacks, encourage exercise, maintain a toileting schedule, let the resident pace in a safe place. So, if you're going to be working in a long-term care or assisted living facility, we have secure areas or floors within the facility. So let me go over here to my pictures. We'll have secure floors or units on the facility where only the staff members will have either special pass cards to get in or out of the elevator, or to get in or out of the floor or unit. Okay, so if you're going to be working in a healthcare facility that has something like that, make sure that you don't let anyone else in or out of the elevator or off the unit that you don't know. Okay, don't automatically assume that, oh, because they're dressed nicely, that they might be a visitor. It might be a resident. That actually happened at one facility that I worked at recently. Okay. And then also make sure that any locked doors, if especially those that require a password to enter, that you don't show the password when you're typing it in into the door lock. You don't show it to the residents or any visitors, because then they might try and enter those secure areas or rooms. Okay, so. But yeah, they would stay in a safe place or a secure unit or floor. So make sure that they don't try and wander off into the elevator, or they try and exit together with a group of visitors or other staff members. Okay. Redirect attention and mark rooms with signs or pictures such as stop signs to help serve as reminders. For hallucinations or delusions, ignore if harmless and reassure. Do not argue and be calm. So if the person is having any hallucinations or delusions and they're harmless, like say if they tell you that, oh, I see ghosts, then okay, you just repeat it back to them. Oh, you see ghosts, Mrs. Smith? And then ignore it. Just continue with the care like we typically would. Or if they tell you that their stuffed toy is their baby, that's their delusion, then okay, they tell you that baby is hungry. They're actually telling you that they're hungry, but they're using their baby, their stuffed toy, as their way of letting you know that they're hungry. So yeah, we would play along with it. So, okay, Mrs. Smith, what would baby like to eat? Does baby want some crackers or some pudding? That's all I have right now for snacks. And then they'll pick one, and then yeah, you just pretend to feed the doll, but you also have the resident eat at the same time. Okay, so okay, let's feed baby. All right, so you have strength to feed, to take care of baby. You need to also eat your snacks, Mrs. Smith, and then yeah, have them eat the next bite. Okay. That's how we deal with it. If they're having any hallucinations or delusions that are potentially harmful, like say, for example, with this current generation of the elderly, if any of them are military veterans and they tell you that I'm back in World War II, I'm under attack by the enemy, uh, take out any potential weapons that they could use to hurt you or the other staff members or the other residents. Okay. For depression, it can be caused by a loss of independence, inability to cope, feelings of failure and fear, facing an incurable illness like Alzheimer's, or a chemical imbalance. So you want to report any signs, observe for triggers that cause changes in mood, like if they seem more depressed than usual, after the family comes to visit, then we want to let the nurse know. And then we also want to find out if the visitor if the resident said anything to the visitor or vice versa that upset the resident. Okay. Also encourage independence, talk about moods and feelings, and encourage social interaction with others. For perseveration or repetitive phrasing, respond with patience, but do not stop the behavior and answer questions each time using the same words. For disruptive behavior, where they're, like, say, for example, banging on the table or furniture, yelling to get attention, that's considered disruptive behavior. You want to gain the residents' attention, be calm when talking to them, and then tell them that you're going to bring them to a private area like their room instead of being out in the dining room or in the activity room. Okay. Ask them about the behavior. Mr. Smith, why were you banging on the table? What was going on? Did you need something? Okay. So that's how you would talk to them. Notice any praise and improvements. Tell the resident about any changes in the routine or schedule. Encourage a resident to join in activities and help the resident find ways to cope and focus on activities that the resident may still be able to do. So, when we say help the resident find ways to cope, if they're showing disruptive behavior because they are seeking attention from us because maybe they don't have any family who comes to visit them regularly, we might give them other ways that they can safely like have that physical or mental stimulation. So either we have them join in group activities or we might give them other activities that they can do by themselves, depending on their likes and dislikes, or if they're feeling lonely, and they want physical attention, um, yeah, we would give them a stuffed toy. That's why you'll see a lot of stuffed toys or animals in a lot of long-term care and assisted living facilities. So if they're starting to feel lonely or they feel a need for physical contact, instead of trying to touch you, or grab other people, we would just give them that stuffed toy to hug instead. Okay. So anytime they feel that urge or they feel lonely, they can love on their stuffed toy instead of trying to love on you as their caregiver. Okay. All right, and then we have inappropriate social behavior. So when that happens, like when they're cursing or yelling or doing stuff that's not typically acceptable in a group, then do not take it personally. Stay calm, reassure, find out the cause. Why are they acting that way? Bring them to a private area and respond positively to appropriate behavior and report any abuse to the nurse. Okay. And then if they have inappropriate sexual behavior, like when they are either exposing any private parts or if they're masturbating in public, then you want to stay calm and be reassuring. Don't be like, Mr. Smith, what are you doing? No, you're going to stay calm and professional. Mr. Smith, you're not supposed to be doing that. Cover them up with a blanket or something else, um, like a towel or their jacket, and then bring them to a private area. Okay. And then consider other ways to provide physical stimulation. Again, that's why we would give them a stuffed toy if they have one. So that way they have that physical contact with something instead of trying to um, touch us or touch other residents. Okay. Also, try to determine the cause of the problem. Is the behavior intentional? Are they actually showing sexual behavior, or are they trying to communicate to us that they had an incontinent episode, or maybe they have a rash down there, or maybe their clothes are too tight, or they feel sweaty down there? Yeah. Those can also look like it's sexual behavior, but it's not. Okay. All right. We're almost done. We have hoarding and rummaging. So to help prevent hoarding and rummaging when you're working in most healthcare settings, except the hospital setting, typically we would label the residents or clients' belongings. That way, everyone knows who that belongs to because it has their name on it. Okay. So yeah, when they're first admitted into the facility or home, you want to make sure to label your clients or residents' belongings per your facility policy and procedure. So you might use a marker, or like in a lot of long-term care and assisted living facilities, we actually have a special label maker that we use, and then we'll just iron it on to their clothes. And then anything that we can't iron on the label, then we would mark it with a marker. Okay. You can place a label or symbol on the door where it has their name on it, or it's something that they easily can recognize as being their room. So that way they know where they're allowed and not allowed to go. Do not tell others that the person is stealing, and also prepare the family by letting them know that, Mr. Smith might have taken something that doesn't belong to him. If you notice anything that any clothes or other items that aren't his, could you let us know and give it to us so that way we can return it to the other resident? See, it's as simple as that. But don't say that, yeah, Mr. Smith stole something, because stealing is purposeful. And when the person is hoarding or rummaging, it's because of their dementia or confusion that's causing them to act that way. Okay. Let's see. And you can also provide a rummage drawer. So in your book, it says to give them towels to fold. We don't do that because the other residents or patients are going to be using those towels. And so any germs that might be on that resident's hands will be introduced onto the towels. And so they will be considered contaminated. We can't use them for anyone else other than that resident. So no, we do not give them towels to fold. Instead, for a rummage drawer, what we would do in most healthcare facilities is we would give them their own clothes to fold. So if they have that tendency to rummage through a drawer, we would give them a basket or a drawer with their clothes in it, and then ask them to fold everything. Okay. And once that's done, then we give them another set of clothes to fold and to rearrange in their drawer to help to satisfy that urge for rummaging. If you don't have anything like that, or the resident isn't or client isn't able to fold clothes, but they can rearrange things, then what you can do is you can also give them a basket that has building blocks in it, or different color balls, and then plastic balls. And then you can ask them to rearrange the building blocks or balls by color or by size. Okay. Or an even more simple way of satisfying that urge for rummaging would be to give them a pack of cards and asking them to rearrange the cards by the different symbols on the cards. Okay. So we would, or by numbers. So you can ask them, okay, Mr. Smith, can you rearrange these cards into black colored cards and red colored cards? Or Mr. Smith, can you separate the house of clubs, hearts, spades, and I forget the fourth one. But yeah, we would ask them to rearrange the cards, and that satisfies that urge that a lot of them have. Okay. If you do find any belongings from another resident in that particular resident's room or belongings, then we need to wash those clothes first before returning it to the actual owner. Or if it's any other item, we need to wipe it down with disinfectant wipes, if you can actually wipe it with disinfectant wipes, before returning it to the original owner. Or if it's a personal care product like toothbrushes. I actually had a patient who would do that. If it's a personal care product like toothbrushes or other stuff that we can replace, we'll just throw that away and then give the other resident a brand new toothbrush or other personal care item. Okay. So. All right, and then we have sleep disturbances. So if the person has trouble sleeping at night, make sure that the resident gets moderate exercise or activity throughout the day and allow the resident to spend time in natural sunlight if possible. Reduce light and noise during nighttime hours and discourage sleeping or napping during the day. Because if they sleep or nap a lot during the daytime, then of course they're going to be less likely to actually stay up during, they're going to be less likely to sleep at night. Okay. So, also, if you're taking care of a client or resident that doesn't like to get up out of bed or get out of their room to attend activities, just make sure that they can differentiate between daytime and nighttime by opening the curtains or shades so that they can see it's daytime during the daytime hours, and then closing the blinds or shade curtains at night or in the evening, so that way they know it's nighttime, and also to help block any outside noises. Okay. All right. And then residents with AD may try to elope or leave a facility unsupervised and unnoticed. So if a resident elopes, then the NA must inform the nurse right away. The earlier a search is begun, the more likely that the resident is to be found nearby and safe. So in a lot of long-term care and assisted living, and I also encourage you, if you're going to be working in your family's care home or adult foster care, or hope to have your own care home in the future, that you take a picture of your client or resident and keep it in their record, okay, or chart. That way, if they do go missing, it's more easy for us to share it with the police, and it'll help them to help us find that missing person more easily, okay? Um, Unlike with other missing people, if you're taking care of a client in your care home, if they go missing, you don't have to wait the necessary 24 hours before reporting it to the police. Okay, you can immediately call up the cops if you can't find them within the house or yard or in the immediate vicinity or street where you live. You can call the cops and ask for their assistance immediately. Okay, so that way they can provide you assistance in searching for your missing client or resident. All right. And then in a lot of healthcare facilities, especially in long-term care facilities, we might use GPS bracelets or trackers, including smartwatches or pendants, or even a smartphone if they have their own cell phone, to actually track the location of the resident or client. That way, if they have a tendency to wander off or to elope, we can more easily find them, okay, and bring them back to the facility or back to our house. So if that is a problem for your client, then yeah, you want to activate their GPS tracker app on their phone if they have one, or on their smartwatch if they're wearing one, or you might want to put a smart tag or attach smart tag to their clothing where it can't easily be removed. So that way you can more easily track them down. Okay. All right. Remember also that people with AD may be at a higher risk for abuse, and one reason for this is that caring for someone with AD is very demanding physically and psychologically. NA should take good care of themselves to ensure that they're able to provide the best possible care. So, like I was saying earlier, taking care of someone who has AD can be very stressful. Knowing that, yeah, you have someone who requires help 24/7 and you can't really get away from them because they live with you. Um, and so make sure that you take care of yourself. If you need a break, then let the other caregivers within your family know, or if you're working in a healthcare facility, let your coworkers know so that way they can cover for you while you take your break, and then you are going to do the same for them when it's time for them to go for their break. Okay? All right, we have the following key term, validating. It means giving value to or approving. And we have the different creative therapies for that are useful for working with residents with Alzheimer's disease. So we have validation therapy, which allows residents to believe that they live in the past or in imaginary circumstances. So an example of that is if you're taking care of a resident that thinks that their stuffed doll is their baby, you just play along with it. So you don't tell them that that's not a baby, that's a stuffed doll. No, you don't tell them that. Instead, we do validation therapy that if it makes it easier for them to actually like eat their food or to allow us to take care of them. Like if we tell them that, okay, Mrs. Smith, it's time for you to take a bath. And they say, no, 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 baby's not dirty. You can point out to them, no, no, baby needs to be washed. Come on, Mrs. Smith. We're going to give a bath to baby. And then you're also going to get a bath at the same time. So you and baby smell good. Okay. That's a form of validation therapy. And usually the resident will actually agree to whatever ADL that we want them to do by including the imaginary character, okay, or whatever circumstances it is. With reminiscence therapy, it encourages the residents to remember and talk about the past. So with that one, if they have any photos or other memorabilia in at their bedside or in their room, then we might ask them about, who are the people in those pictures, or we might ask them the importance of those medals or trophies or other stuff that they might have at their bedside that we know is important to them. Okay, so they get to reminisce about their past experiences. Okay. Eventually, of course, they're not going to remember any of those details. And so, what we oftentimes do in some long-term care facilities or memory care units is that when the resident is in early stages of dementia, we'll take a post-it note and then write down what they told us about that picture or about that memorabilia that they have at their bedside. Take a post-it note, write down the details that they shared with us. It might be wrong, it might be the truth. Okay, we don't know, right? And then yeah, put it or stick it to the back of that picture or stick it to that medal or other item that they value. And then that way, when the resident's dementia gets worse, we can remind them, remember this, Mr. Smith? This is your wedding photo from way back in 1952 or something like that. That's your wife there in the middle, obviously. Her name was, and whatever her name was. Okay. And we would have all that info on the post-it note. Or we could also ask the family to write down information on the post-it notes and stick it onto those pictures or other memorabilia. We don't typically write directly on the picture because then if the resident tells us the wrong info, then of course the family gets upset with us, and that's why we'll write it on a post-it note instead. Okay. And then another therapy that we might also do is activity therapy that uses activities that the resident enjoys to prevent boredom and frustration and to promote self-esteem. So that one is the most common one that you'll see in a lot of healthcare facilities, especially long-term care and assisted living facilities. We might have group activities that the residents can attend, like watching movies or TV shows, doing exercise therapy with each other, playing games, doing arts and crafts, that they can also do either by themselves or with other people. So those are all different activity therapies that they can do. Okay. And then the very last type of therapy that we also use a lot in long-term care and in other memory care units is music therapy. So music therapy has been used successfully with people who have AD. Music is a form of sensory stimulation, and hearing familiar songs may cause a positive response in people with dementia who do not respond well to other treatments. Music therapy may be utilized to accomplish specific goals such as managing stress, improving mood, or enhancing cognition, letting them remember things. And so the NA can help by observing the resident's response and playing music that the resident enjoys. So make sure that you play the music that the resident is familiar with. Don't be playing Beyonce or Taylor Swift or anyone else like that, like current generation. You need to be playing music that the resident knows and enjoys. So, like with this current generation of the elderly, you want to play Elvis Presley or Elvis Costello, Frank Sinatra, uh, as an example of some singers, whose music that they might enjoy. Okay. And we oftentimes will also ask the family what the favorite song or music is for that particular resident, so that way anytime that they are feeling lonely or sad or upset, we can play those music or songs to help to hopefully boost their mood and to make them happy again or help relax them. Okay? So that is the end of chapter 5. All right. Thank you, everyone, Marisha and Jerem, for staying. That is the end of the lecture. I'll see you all again next week. Have a great week. Okay? Take care. Thank you. Bye, Marisha and Jerem. Okay? Take care.